Yeah. Open
Good evening, all, and welcome to the session. So we'll be talking today about the November exam. Am I audible? Can I please confirm am I audible?
Yes, ma'am, you're audible, ma'am.
Yeah, thank you, Dr. Manikam. Right.
Thank you, ma'am.
So yeah, so we'll be talking about the November Part 3 exam and the face-to-face exam. We are reverting back to the pre-COVID days. We'll just wait for another 3 minutes for some of our colleagues to join. So then we will carry on. Thank you. Thank you for your patience. So let us start with our session today. Thanks all for joining. So this fine evening, my dear friends, we will be talking about two things. I'm Dr. Guna Krishnaveni. I'm an Royal Collection member as well as I'm an international affiliate of SFSRH. And we will be talking about the content. The agenda of the meeting is we'll be talking about the content of the exam and the methodology of the exam. Right. So before me getting into the content, I'll be telling a few alterations that happened because of the COVID issues and how we have reverted back. We are trying to revert back to the pre-COVID days. So what I mean by that is the pre-COVID days, there used to be a face-to-face exam. That's because of the COVID pandemic. There was a break in 2020. There was no exam. I would say actually from 2019. And 2020, there were no exams. And then finally, we started reverting back to normalcy thanks to our vaccinations and all our global vaccination programs. So from 2021, it became an online exam. And from 2022, May, we have started again face-to-face examination for the eco candidates, and online was continuing for the rest of the global candidates, right? So in November, it has been announced by the college that we will be having a face-to-face examination for the UK as well as the previous centers of the RCVG, peripheral centers, I mean to say the global centers. But the rest of the centers could be online as well. So at the moment, we are just waiting for the updation from the RCVG. So what new centers would be included and whether they'll be hybrid. So what sort of further information we are able to get announcement from the website. So having this brief introduction, so let me continue with the further section. So believe me, friends, you are here because you have put all your efforts and time and money and did a lot of sacrifice together as a family, sacrifice your practice, all these things, and you're sitting here on this part 3 session course because of all this hard work and effort. So believe me, if you have come till part 2, that means you're the last leg of this journey of Mrcog. So believe me, this is going to be definitely a doable exam. If all of us can do, you can as well do, right? The need of the hour is strategic planning. So November 7 is your exam. Today is July 7, right? So how many more months do you have exactly to say is August, September, October, and you're on November. So exactly, so that's the reason that I arranged the schedule on this particular day, right? Exactly 4 months. So strategic planning is the need of the hour. So we'll be talking about the syllabus, the modules, and the domains, and the type of the tasks that we are going to discuss. That is a simulated patient task, the structured discussion, the teaching tasks, and those tasks with a lay examiner or not. All right. Right. So before, as I told you, before I get into the content of the exam, the methodology of the exam, it should be a face-to-face or an online. So we will be practicing you both for that. So do not worry because we all are, we can belong to anywhere else in the globe. So we can be UK candidates or non-UK candidates. We can be candidates who belong to those centers who have been previously announced centers for the RCVG. I mean, to say it could be centers in Chennai, it could be centers in Hong Kong, it could be centers in New Delhi, it could be anywhere, right? So those centers will have face-to-face exam, but the rest of the globe might have an online exam. So we will be coaching you for both. Do not worry about that. Right, the face-to-face exam. So dear friends, imagine this is going to be a cabin. You'll be entering into a hall and you'll be facing this cabin. And you'll have 2 minutes, this posters. This is your cabin number 1, 2, 3, 4, the circuit exam, starting from 1 to 14. Okay, you will start at task number 1 and you'll go to task number 14 at the end, or you might start in task number 5, and you might finish in task number 4. So it's going to be a circuit exam. So 14 candidates in the morning slot, 14 candidates in the afternoon slot. And we will be teaching you all the tips and tricks, how you should excel, how you should be the best, how a SmartMed candidate will be the best of the 14 candidates in the task. Right. So the face-to-face exam, you have 2 minutes preparation time and 10 minutes. Sorry, it's not it's a performance time. It's not the preparation time. Sorry for the spelling error. This is the performance time. Okay. Right. So 2 minutes is your 12 minutes task, 2 minutes reading time, and 10 minutes is your performance time. And what you're going to do in the 2 minutes? There'll be an instruction which is placed. If you can see closely, this instruction, candidate instruction paper, which is posted, you'll be given a notepad and a pencil. You'll be reading that and you'll be making short notes of whatever is given, and then you will enter the cabin where you will be seeing 2 people, 3 people, or 4 people. So I'll tell you each what I mean by you'll be facing 2 people, or you'll be facing 3 people, or 4 people. In my following slides, I should be able to explain to you. Right. So these are the particular domains that you'll be examined. So some of my part 2 candidates are also here. As I told you, I've always been telling you in my part 2 sessions that this is going to be a little different platform, the part 3. All right. So this is not where you can study by yourself or practice by yourself. You definitely need someone to be in your team, your study team. So we'll be telling you about all those things. So the particular domains that will be examined here is your information gathering, communication with patient and relatives, communication with colleagues, patient safety, and applied clinical knowledge. Okay. So what I mean by applied clinical knowledge, whatever you have studied in your part 2, the 100% of what you studied in your part 2, you're going to take and apply as 20% in your part 3. Right. So your applied clinical knowledge forms 20% of all your domains. The rest is the above mentioned 4 domains. Now the module. So you will be examined in teaching module, core surgical skin post-op care, antenatal care, maternal medicine, management of labor and delivery, postpartum problems, gynae problems, fertility, sexual and reproductive health, early pregnancy care, urogynecology, and pelvic floor problems, and gynecological oncology. Right. So the type of the stations could be a structured discussion, a simulated patient task, a simulated patient task with a lay examiner. So what I mean by this? So let me come back to what is meant by simulated patient task. Simulated patient task is at RCVG, they do not ask you to stay bedside, they don't give you a couch or something. So they'll be giving you a simulated role player, rather an actor. Just like how you and me are professional doctors, they are professional actors, drama artists, or they will be having their own script to speak, and they will have their own emotions to enact. Okay, so these are called the role players. Okay, so there's a patient, or rather there's a role player is going to simulate a patient. So this is what we call as simulated patient tasks. The next is the structured discussion. It's just nothing but you'll have to talk to your chief or your consultant or your boss or your head of the department, or whatever you call it, as way back in your own places. So structured discussion is just you and the examiner. And there's something called as lay examiner. So what I mean by lay examiner is, this lay examiner is someone from the public, from the community, from the society. He is a non-medical person. He or she is a non-medical person. She can be an advocate. She can be a teacher. He can be a carpenter, a bus driver. So anybody from the society who is going to check you on your communication skills. How are you good as a doctor to him or her, as well as to the role play. All right. So this is one of the most challenging aspects that candidates generally find difficult in clearing. But believe me, it is you're going to score the best or the maximum number of marks will be with the role with the lay examiner task. Okay. So remember, the examiner is a non-medical person. someone from the community, someone from the society who is going to give, who is going to assess you on how far you're a good doctor to him, as well as to the role play, to any patient for that matter. Right. So having spoken that, so let us start to discuss a little more in detail. As I told you, there'll be some simulated patient tasks, right? Structured discussions, and there'll be teaching tasks, right? So believe me, friends, this is going to be a totally interactive exam. This is not going to be a lecture. This is not going to be, someone speaking, someone listening. It's not going to be an interview. It's not going to be an interview. This is not going to be an interview. This is not going to be a lecture, but it is just going to be an interactive session, right? So just how you day-to-day interact with the patient, but it has got certain skills as far as and you have to keep up the standards of the SUG. So what I mean by that is you'll have to talk, allow the role players to talk, allow the examiners to talk. I'll come in detail when I come in the following slides. So guys, you have 14 tasks, 14 stations. You have 2 minutes preparation timing and 10 minutes performance training. So we call it as performance. We don't call it as anything else, right? So it is not like an oral exam. It is not like I would not say it is going to be 100% viva. It may not be the same that you had done in your postgraduate days, way back in your places, way back in your countries. So this is going to be something different. So that is what we call it as performance. We don't call it as viva. We don't call it as oral assessment. We don't call it as interviews. We don't call it as anything else. We call that as performance. All right. 2 minutes to read and to take notes. The online exam will have an extra 30 seconds. That 30 seconds is for the slide to switch over. And you'll be given a notepad, a digital notepad, where you can type whatever you are supposed to, whatever you want to type about that particular task, and that could be that is only visible to you, not to the examiner, neither to the role player. Yeah. 10 minutes is your performance time. So we aim to get you prepared in 9 minutes, so that you will have that one, at least that last single minute to communicate with the role player, right? So the one line take home messages, please allow the role players and the examiners to talk. Believe me, they are here to help you out in the event of you go a little bit out of the track. You go heavy in the nervousness of the exam, you tend to miss something. So they'll prompt you. So don't worry if they prompt you, they are going to help you. At the same time, if you do not ask a particular question, or if you are not answered in your presentation about certain things, so she will give you a clue. She can give you something to, that is their part of their script. As I told you, they are also professional actors. They have got their own script to speak, the dialogues, and the emotions to enact. All right. So in their script, they'll be given, if this particular candidate is not coming out with these details, if he or she is not discussing certain things, you can ask these questions, right? So if you do not ask, if you do not have time to inquire into her, her tasks, her needs, or her whatever her concerns, if that is incomplete, then in spite of having done a good performance, your station might go as a borderline. So what I mean by borderline, I'll tell you. So yeah, the type of the stations, this the structured discussion. Yes, let me get back to my cabin. Yes. So I said, when you enter the cabin, you'll be seeing 2 people. So 2 people are nothing but you and the examiner. So that means it's a clue that it's going to be a structured discussion. Of course, it will be given in the candidate instruction very clearly that this is going to be a structured discussion or a case-based discussion between you and your consultant, you and the examiner. Okay, certain things will be given. But in the event of you getting nervous, because candidates generally tend to, the initial 15 seconds, they get nervous in the 2 minutes time. Somehow they tend to miss the information which might be given in the first few lines. So, but clue for you is if you see two people, all right, that is you and the examiner. Okay, that means there's a structured discussion. If you're going to see three people along with you, there is two people plus you. That means it's going to be a simulated patient task, a role player task. That is, one will be the examiner, the another will be the role player, and then it is you. There'll be some cabins where you'll be seeing three people plus you, that is totally four people. So that means there is a role player, there is an examiner, and there is a lay examiner. And believe me, the more the number of people, if the more the cabin is crowded, the more marks you will get. It's just a joke. What I'm trying to say is these stations with the lay examiner carry the highest mark. So let me come back to the mark distribution. So this is why we call it as information gathering. All the 5 domains, either it is score 0 or score 1 or score 2. Score 0 means you have failed in the domain. Score 1 means you've scored borderline. Score 2 means you're past the domain. So mark distribution, as I told you, lay examiner stations carry the maximum marks. The role player tasks generally carry 4 domains, minimum 4 domains, sometimes 5, all the 5. And the lay examiner will have 3 domains to score you. So totally around, you will have 8 plus 6 plus 14, sometimes 16. So maximum score for a single task. Believe me, if you're going to score all the 14 tasks, all the 14 marks in a single task, and if you're going to do that, so what's going to be, you'll be the gold medalist. All right, so at least you should be able to score maximum marks. This is a sort of a plat or ground where you can keep on getting sixers. Okay, hitting sixers. It's going to be a 6-hour task for you. The next is the role play task. You'll be assessed in 4 domains at least. Sometimes you might have 5 also. So that carries 2 into 4 is 8 marks. And the rest is the structured discussion. It is between you and your examiner. So 2 people, least score. So you'll be assessed in generally 3 domains, very, very rarely 4 domains. So 2 into 3 is 6 marks. Generally, there'll be a 6 patient simulated tasks, and out of which there might be around 3 to 4 lay examiner tasks. Sometimes there'll be around 4 structured discussions will be there, and there'll be sometimes a simulated colleague task will be there. That's a teaching task. Okay. Generally, for the online exam, there is no props. They will not give you any forceps or any mannequin or any pelvis and doll. Such things will not be there in the online exam, but it is there in the face-to-face exam. All right. So let us talk in detail about the role play tasks. Any doubts so far, dear friends? Any doubts so far? Are we good to continue, guys?
No doubts, ma'am.
Okay, thank you. Right, so simulated patient tasks. So there's something called this agenda fixing. So we will be telling in detail what is that, okay? We are discussing about the information gathering, the domain that includes the history, the examination, and the investigation. So the time slot for is 3 to 3.5 minutes. The agenda fixing is 50 to 55 seconds. So let me come back to that. Again, I'll be repeating this when I do the templates with you, right? So today for a model, we will be doing an early pregnancy template for you guys. And then we'll be talking about the applied clinical knowledge, where what I mean by applied clinical knowledge is not what and all you studied in your part 2, not what and all is there in your memory in your part 2. No, we don't do that. Not what and all the values, the numbers that you've read in your part 2, the percentages. No, we don't do that. We don't need that. We want customized, tailor-made knowledge for that particular task or what the role player demands. So that will be 4 to 4.5 minutes. So all these will be winding up in 9 minutes. So the last 1 minute is for the role player to raise her questions, if at all, if if you have missed something or if you haven't answered anything which was there in her script. So believe me, the carry home message is please allow the role player and the examiner to talk. So what I mean by examiner to talk, I'll let you know in the next slide. So the more the role player talks, the more marks you will gain. Structured discussion, there's something called as S-bar tool, the situation, background, assessment, and recommendation. So we'll be teaching in detail when we start our orientation courses. So when we start our course, we'll be teaching what is meant by S-bar tool, the situation, background, assessment, and the recommendation is the communication tool that RCUG recommends when we communicate with the colleagues. Please, this is an exam of justification, dear. So please justify whatever you're doing. Justify to the role player, justify to the examiner. You should have evidence-based justification of whatever you speak. And unless and until you do that, this is not going to get done with that. So for structured discussion, believe me, time is never a problem. Here again, allow the examiner to ask questions. What I mean by that, you will be generally finishing the tasks. Maybe instead of 10 minutes, you'll be finishing at 6 or maximum 8 minutes. Okay, except labor prioritizations, word prioritization, such things, you'll be able to finish it. So still, there might be something that the examiner needs to ask you. And if you don't allow him to ask, if you go on and on and on and on and talk, the problem is, guys, people have to understand what this exam is all about. It's not a part 2 exam. It's not your where we are going to assess your knowledge only. You have the rest of the other domains to be worked on. And unless and until you are going to be very clear of what is this exam about, it is very difficult for anyone to sail through this exam. And that is why we are sitting here to discuss, to tell you what this exam is all about. All right. So what I mean by is sometimes the examiner will ask you, what is the antenatal management of this woman? Our candidates in the specific exam, they will start talking about antenatal, intrapartum, postpartum, contraception, and come to the pre-pregnancy counseling. Unfortunately, you're eating your time. So the examiner will have some set of questions to ask, but you will think that you're oversmart. You're oversmart by answering all the information that you have for this particular scenario, and you feel that you are oversmart than the examiner. But believe me, he will not score you for whatever you're going to say. He's going to ask you only about the intrapartum care or antepartum care. Please talk only about that and just pause. Pause for 5 seconds. He will come up with the next question. All right. But if you think that, okay, the examiner has asked me this and I'll have to speak whatever is there, then only he will think that I'm a knowledgeable doctor. No, believe me, it's not so. It seems that you do not have situational awareness, or you might be under the stress of the exam that you just tend to skip over what is being asked to you and try to overtalk and lose the time. So the next question is going to be again intrapartum care. So doctor, could you please tell me how you're going to manage this woman when she comes to the labor? So that is when you have to talk. But you will think that I have talked about all these, and people tend to be a little careless in answering the second question, they will lose the mark. So if you go on and on like this, the 10 minutes will be over. And it's a very simple session. It's a day-to-day clinical practice that you see. You could have discussed this with your own consultant, with your own boss, your chief, hundred number of times. And you really feel that, oh, I've done this task very good. But believe me, that is not it. You might go for a borderline because you didn't have time to answer all the 4 questions or 5 questions that was there. Okay, so he couldn't mark, the examiner couldn't mark your score. So this station would have gone for a borderline or a fail in spite of knowing this station by heart, having the proper clinical knowledge. So as I told you, it's a totally interactive exam. You have to be very alert and very attentive when you listen. So allow the examiner and the role play to talk. So labor prioritization, previously on the online exam, we used to have 15 tasks, 15 rooms, 12 rooms, and all that was there. In the May exam, For the face-to-face exam, for the UK candidates, it was a little prolonged. So there's more than 20, somewhere 18, and all that. But thankfully, for the online exams, it was just 8 or 9. So we do not know. Do not worry. We will be giving you adequate training to face all these. And something we call as gynae ward, where we'll have to spend around 1 to 1.5 minutes per room, generally around 4 to 5 rooms. You'll be able to finish on time, if not before time. Right, the syllabus. We have all these books, the Lisa Joel book, Onji book, Get Through, Oxford, Tony Olympic, 50 cases, basic practical skills, all that is available. So I have put basic practical skills. This is not part of your task book, but this is what is RCOG's recommendation, especially when you talk about um, like for example, the mechanism of you know, how you manage the shoulder dystocia, or how you're going to take a fetal blood sampling, you know, such skills, the practical skills, you're expected to speak exactly what is given. So I would recommend each and every one of you to have a soft copy of this book. If not, I can share it for you in the group, guys. So please, RMC, when you're at home, when you're sitting in the clinics, you can just go through this book so that you can get familiarized with the terms. You might be doing in and out in your day-to-day practice, no worries, but still, at Fuji will be, you'll be expected to speak these words exactly. That's why I highly recommend this book along with the prompt manual. So again, prompt manual, you'll have to be, it's not that you have to be well versed, but still you'll have to be, you should have at least read the prompt manual twice. All right, so you're going to get, you as expected, you might get a lot of, the so-called recall stations or repeat stations. So we will be talking about, you'll have to read the PILs, the RCOG PILs, the NHS conditions, so all that we'll be sharing for candidates in the Google Drive. You'll have to go through the strategy videos, some exam tube videos. They may not be exactly the scenarios that you will get, but for the communication skills, if anyone is interested, you can subscribe to the exam tube, and you'll be given a set of videos. You can see the slang, not the slang, exactly the pronunciation, how they speak. That might help you in improving your communication skills. You'll have to you can also in the strategy, there are some case-based discussions which are given. You can go through that also, and the summaries of the guidelines and the algorithms, and the prompts manual, as I told you, the embrace, the latest at least 3 years embrace reports, and the last 3-year talks. The last 3-year talks, you might get a task, a patient simulated task, or you might get some structured discussion. So please be, you may not have to learn by heart, but still you should be knowing the content of the last 3-year talks. So we got a very good result of 80% in February 22, and the top score was 878. Our May results was 95%, and the top score was 80. So please, guys, very, very important take-home message, the points to understand about this exam is you expect it to be a safe, a knowledgeable, an empathetic ST5. ST5 means a middle grade doctor, specialty training 5. A middle grade doctor with a good set of communication skills. That's what you're expected to. It's not sufficient if you're just knowledgeable. You need to be safe doctor. You need to be an empathetic doctor. You need to have good communication skills. And you need to be a middle grade doctor. ST5 means a middle grade registrar level doctor. So a middle grade doctor is the one who seeks guidance and help and support, as well as he is obliged to inform his consultant, his or her consultant, and take his opinion and involve him in emergencies and complications, right? So he's the one to seek, to look up for guidance, as well as he's a middle grade doctor, meaning to say he is not the junior most in the cadre, so he is obliged to teach his junior colleagues, his junior colleagues. He has to interact with the midwives. He has to interact with the team members, the junior members, and there's something called as a teaching task. So out of all these tasks, there's something called as a teaching task where you'll have to teach your junior colleague. So you'll have to teach it to your junior colleague. It could be a specialty training year 1 or 2. It could be a foundation year 1 or 2. All right. So something what we call as internship. It could be just, your first degree or your first year postgraduate, So junior colleagues will be there and you'll have to teach them. Sometimes, very rarely, you'll have to interact with your midwife as well. So that is a rarely comes. Generally, it's a teaching task for a junior colleague. So you are supposed to have all these to clear this exam. You're supposed to be a safe doctor, a knowledgeable doctor, an empathetic, middle grade doctor with a good set of communication skills. Common platform as far as this exam is concerned. So what I mean by that is we are all we could be in different age groups. Some may be in the age of between the ages of 20 and 30 years, some 30 to 40, some 40 to 50, some 50 and above. As well as you may be just a beginner in your career, you may be a fresh, an undergraduate with a bit of OG experience, maybe around 4 to 5 years of OG experience. You might be a registrar level doctor, you might be a top level consultant, you might be working in the public sector in your own countries, you might be working in your private sector, you might be working in a corporate hospital, you might have your own setup, you might be a medical director of your own 300-bed hospital. You might be just a beginner with a clinical experience. You might be a postgraduate, a double postgraduate in your own countries. You might have humpty number of fellowships. So you might be having, so many degrees. You might be a PhD. You might be a research scholar in so many ways in your specialties, right? But for here, everybody has got a common platform. So what I mean by that? So this is what I meant by a middle grade doctor who's going to seek. You might be a decision maker in a hospital. You're the one to decide you want to do a cesarean section for this patient. You might be the top level consultant under whom you have 10 consultants to work under. But as far as this exam is concerned, my dears, you have to understand this particular fact that we are middle grade doctors, irrespective of our age, irrespective of our experience, irrespective of the setup that we work, irrespective of however we have been through so far. As far as this exam is concerned, you are a middle grade doctor. You are in the cadre of a specialty trainee year 5, whom you're above whom is a consultant, and it could be the junior colleague the next to you who is seeking your guidance. It could be a midwife who wants to get some advice regarding a patient. So it could be anyone, right? So you are a middle grade doctor, and that is why it's very difficult for people to unwind from whichever roles they are playing in their actual real life to sit at this exam. Really, my dears, they have come across so many candidates who are excellent in their specialties, in their subspecialties, as well as they have a rolling practice. They are, top level doctors in their public sector hospitals. Very, very happy about that. But as far as this particular exam is concerned, this is a common platform. And you have to understand that and kindly unwind yourself and get yourself into this new role of a safe, a knowledgeable, empathetic, middle grade doctor with a good set of communication skills to at least till you clear this exam. So please understand this fact very, very clearly. And if you're going to unwind and keep this thought when you start preparing for your exam, when you sit with your study partner and practice, when you attend the sessions, when you attend your mock exam, believe me, it's going to be a smooth sail. Otherwise, it is not going to be. Right. So you are being examined in your clinical skills, in your leadership skills, in your managerial skills, and your teaching skills. So what I mean by the clinical skills is your day-to-day, your treating, your how you treat your patient, how you're going to do surgery skill, how you're going to deal with the post-operative complication, all your technicalities. Your leadership is when you are a labor ward leader, a labor ward coordinator who is going to prioritize the tasks, the rooms according to the urgency level. You're going to prioritize, you're going to allocate who is going to attend which patient, who is going to, where the consultant is going to come, where you're going to go, where you're going to involve some specialists, where you're going to involve the anesthetists. So you are the team leader of that particular day in the labor ward, and you will have to have leadership qualities. You have to have teaching qualities, teaching skills when you teach your junior colleague in the teaching task. And you need to have managerial skills, how you're going to do, the clinical governance aspect, how you're going to deal the risk management of a particular never event, how you're going to manage an angry patient, how you're going to manage um, some delay in the OP. Okay, patient is coming and shouting at you saying that she was being delayed for 2 hours, and how you're going to manage with such things, and how you're going to organize your audit, how you're going to organize your metadata dashboard, and how you're going to discuss about your metadata dashboard. So all these aspects are going to be tested in this. So you need to have all these when you sit for this exam. And believe me, this is not going to be a single task which is going to say only your clinical aspects or only your management. This is going to be part and parcel of most of the tasks. Part and parcel of, not saying all the tasks, but most of the tasks. It is something like it is you will be seeing the flow. As you see the flow, you'll be able to find, okay, this is where I'm being tested as a leader, this is where I'm being tested as a clinician, this is where I'm being tested as a manager, this is where I'm being tested as a teacher. So unless and until you have this understanding of how to approach this exam, it's very difficult, my guys, to clear this exam. I have personally seen so many candidates who really do excellently, extremely well in the part one and part two, and come out with very, very good scores. But unfortunately, they don't clear the part three exam because this is totally a different stage, a different platform, not your part one and part two. So you need to have that understanding, and that is the beginning of this journey of the last leg of this part three, Mrcog. Yeah. All right. So right. So what we will be doing for you is what you are supposed to do for this exam is you need at least one minimum study partner, two or more, two or three will be ideal, at least one. And all of us are busy in our own careers, with the jobs, with the families, with our commitments towards the patients, to our everywhere else, right? So split your study timing into 2 or 3 sessions per day. It depends. Like sometimes if you're free in the morning, you can have a session. You can have a study session with your study partner if he or she is also available at that particular point of time. Sometimes in the afternoon, sometimes in the night. But at least you will not be able to sit for 3 hours and prepare in the initial stage. But we will be giving you guidance as you progress towards the exam. Okay. So try to split your study timing into 2 or 3 sessions where you can interact with your study partner and start preparing for your exam. Okay. So what we will be doing in the morning slot is that, yes, someone is asking me a question. Sorry, okay, Nihal, please carry on. We have spoken well about this in the course. Carry on, my dear Nihal. And this recording will be posted and you can listen to the recording. Thank you. All right. So the morning slot, generally we call it as repeat stations or your recall stations. Afternoon slot, you can do your books. At night, you can do some random stations. You can discuss something from the talk. Welcome, my dear Nihal. So always try to do a video practice with your study partner. Suppose if you live nearby or in the same, in the same apartments, or if you stay in the, if you are going to do a duty together, you can discuss in your lunch break after your OPD. So if the two of you are together face to face, then it's going to be the best. If not, at least do a video call and do the video presentations with a timer and record the demo. So that will be very much beneficial. So this is, as I told you, this is a performance. So this is a performance. What I mean by the performance, your facial expression. So I was telling you, you have to be an empathetic doctor. So what I mean by that, your facial expression. So you cannot laugh at a woman who's going to whom you're going to, break her back and saying that she's lost her pregnancy. It's a miscarriage, and you cannot laugh at a patient like that. Okay? So you have to emote to the role player's emotions. You have to answer the questions. It's not just answering the questions, this, that, and all that. You have to really emote. So this is why I told this is performance. Okay. So when you do a video task, so there is different position of sitting, different position of keeping your hands, definite position of, leaning a little forward, and definite, ways of emoting, the facial expressions, maintaining the eye-to-eye contact, and minimizing the hand gestures and the nodding of the head and all those things. So you need to practice that with your study partner, and we'll be training you up when you come for the courses. So if you do not able to meet your study partner any part of the time or any part of the day, or you stay in a different city and she stays elsewhere, or she stays in another country, and you stay in some other part of the globe, that's absolutely fine. So please do a video practice. There are so many apps nowadays, the Skype, the Zoom, so many other apps as well. So you can just utilize one of them, and we will be you can do a video practice with a timer and record them. So what I mean by the timer is very, very important, my dears. Candidates struggle with the time, and we will be coaching you how you'll be managing with the time. Do not worry, but you have to perform this under time restricted environment, right? So this is not your if anyone is given 20 minutes or half an hour to perform a task, everybody will score 100% in this exam. No, that is not the case. So you'll be given just 10 minutes, and that is why candidates do literally struggle with how they are going to manage. And that's why we gave them all the schedule of how they will be preparing. For example, I was telling them you have to plot this particular timing for the agenda fixing, this timing for your information gathering, this is for your applied critical knowledge and all that. So I'll be letting you, as I do my templates, I'll be telling you what is that. All right. And when you go through the exam, at least arrange 3 weeks leave before the exam, and arrange everything with your job, with your home, with your family, with your kids, and allocate these 3 weeks devotedly for your exam at least. But the rest you will start preparing from now. Today's July 7, and your exam is November 7. All right. So before I go for the task of the day, I will tell you what we are going to do for you. So the action plan for 2022, we have the courses and we have the mock exams. So our course will be having 12 weeks course. We are starting from August 1. This is for the November batch. And we also we have already started batches from July 1st for it's an ongoing batch. But for the next batch, the 12 weeks batch is starting on August 1. But we have something in between that we got as a 14 weeks course, and we'll be having we'll be starting on July 14th, so the 14 weeks course, and we are the first ever in all of the among the mentors, all among the courses, to give a mini mock at the end of every 4 modules. So we have 14 modules. So at the end of every 4 module, we will be giving you a mini mock to assess where you stand, and we'll work on improvising. So we're not someone to finish the course, finish the session, wash their hands and go. I'm not the person like that. We, for that matter, we are all in SmartMed. We are of that. We are a big family. So we don't just leave you by conducting sessions and then forgetting you, and then coming back to you after a week and never mind about what you're being given so far and what is your level of improvement in performing the tasks. Okay, so we will be giving you homeworks. There's a moderator to monitor you guys. My part 2 guys know well about the homeworks and sessions and things. The part 3 also we will be doing, and we will be giving you mini mock exams at the end of every 4 tasks. So that's why we have very, very limited seats, because we don't run big batches. We don't want to run after so many people, so many things we want to do. I personally believe in teaching, quality teaching, right? So I don't want to have big batches, big classrooms, nothing like of that sort. I just want to do some quality teaching. So that's why we recruit only 6 candidates per batch. So we don't take more than 6 candidates per batch. And yeah. And as I told you, we have a 12-week session starting from August 1. We have the 14-week session starting from this month, that is from next week, from July 14th. And we have the one-to-one session, which is already going on. So one-to-one session means where only that is between me and the candidate, right? The mentor and the candidate. So this again is started and we are going on. We have just got 3 more seats left. And then we have something called this first ever time that is uh, coming among all the courses is for the repeaters. So for the repeaters, so already been exposed to the exam ones who have been preparing for 6 months, 1 year, who couldn't get a slot or who got a slot and who, unfortunately couldn't clear. These we call as repeaters, and we don't want the repeaters to join us for a course because it's a sheer waste of time for me as well as for you, right? So I don't want you guys to start from the alphabet, and I don't have time to teach you guys who already know the alphabet, right? So you are already some 20-30%, and my duty is to push you to achieve that 100%, right? So this is we call it as smart sessions, where you guys can choose any 3 modules of your choice, and we'll be spending 3 hours for a session, and we'll be discussing around 9 to 10 tasks, and you will be coming alone or you can come with your study partner, because I know repeaters will be definitely having 1 or 2 study partners already, and you can come together as a group, as a team to have yourself improved, and it's totally up to you. So yeah, that's what I'm giving, only customized, tailor-made teaching sessions, right? Not the traditional teaching sessions. Yeah, registrations are closing on, and we'll be having special sessions towards your booking. So we'll be teaching you all the tips and tricks. And personally, I've guided so many of my candidates. I've done a conferencing to all my candidates, and see to that they do get the slots. So the slots are finished within few minutes, less than 5 minutes. So we will be teaching you all the tips and tricks of exam booking. When the exam dates are out, we'll be having special sessions to teach you guys. Don't worry about exam booking. So as far as that is concerned, so the strategies is together we can, and it's a teamwork where you will and I will. So my success is your success, our success is your success, and your success is our success. Right. So having said that, so let us go for the task of the day. So I need Tahira. Are you there, my dear?
Yes, I am here.
All right. So are you ready for a task, my dear?
Okay.
Yeah. So let me start with that. Okay. So I will have to focus the timer, so which will make me come out of. So before I go for the task, I want you, Tahira, just excuse me. I want you guys to know about the templates. I'll just give you a sample template of what we have done for the early pregnancy module, and then we will go for the task. All right. So this is the early template module. It's a sample module that I'm showing you a template. Is my slide visible, my dears? All right, so let us start. This is a template for simulated patient tasks. So generally, the introduction is, hello, I am Dr. So let us say Tahira. Hello, I'm Dr. Tahira, one of the doctors. So you'll have to introduce yourself to whom you are and what's your role and where you are. So this we call the situational awareness. Hello, I'm Dr. Tahira, one of the doctors in the early pregnancy assessment unit. Hello, I'm Dr. Aisha, one of the doctors in the maternal medicine clinic today. Hello, I'm Dr. Arya, one of the doctors in the urogynec clinic today. So that has to be introduction. May I check your name and age, please? So you could have been the repeaters, could have been taught in different sessions. Can I confirm your name? Can I confirm your name? So believe me, English is such a beautiful language where we'll be talking about, there's a lot of difference between can I confirm and may I check. It doesn't, we are not teaching English grammar for you. This is not an English course, but this is a communication skill. The other day, one of the other days, we had a GMC webinar where we were, the webinar, 40 minutes of the webinar was telling us about the usage of the words must and should. So the practice is, Humera, it's okay. I can see that you have some network issues. Don't worry, my dear. So we'll be sharing the recording slide. So there's a lot of difference between can I check, can I confirm, and may I check. So what do I mean by that? It sounds very silly and trivial, but believe me, it's not so. It carries a lot of weightage. So what I'm trying to say is, this is an RCOG exam. This is a UK-based exam where, as I told you, we are all in a common platform. Whatever may be your age, whatever may be experience, whatever may be the previous postgraduate degrees, we are all in a common platform. So the common platform includes the patient as well. So here it's always a shared discussion, a shared decision making. At no point in your discussion, you can never ever make the patient feel that you are a dominant person or you are trying to dominate the patient because you're a doctor. No. So it's always a shared decision making, a shared management plan. So you are a medical personnel. You have the patient sitting in front of you, a fellow human being. You are here with all your medical knowledge overflowing from your head to speak in a patient-friendly language. Believe me, it's a patient-friendly language, not your medical jargons. Abdominal examination, tummy examination. Abdomen is a jargon. Jargon means a medical terminology which you're not supposed to speak to the patient, not supposed to speak to the role play. You're supposed to call it a tummy examination. I would like to examine your tummy. Will that be okay in the presence of a chaperone? So that is how you have to communicate with the patient. So you can, so the RCOG gives a list of patient information leaflets, and I'll be showing this at the end of this slideshow about the patient information leaflets, about the medical terminologies and the concerned layman terms, so that you'll be able to memorize those things by heart, and you'll be able to practice that with your study partner, and that is where your important score lies for your communication with the patient. And if you're not going to do that, believe me, my friends, it might be very, very challenging for you to pass this exam. Right. So if I say, may I check your name? So that means that I am empowering my patient that she is equal to me in all respects. I'm here as a medical personnel, as a doctor, to discuss about her, to give her, to explain her condition, to ask her questions in a patient-friendly language, to collect information from her, to say my diagnosis in a patient-friendly language, explain to her the diagnosis, and offer the treatment options in a patient-friendly language, so that she will be the one to decide what is her choice, and whatever is her choice, you and your team are supposed to help and support her. So that is going to be this task, this examination of which carries the simulated patient task. Yes, in your structured discussion, in your case-based discussions with your examiners, structured discussions, you have to speak only as a doctor. You're just communicating with your boss, with your higher up. Okay, so there you can use what in all medical terms you ought to speak, you have to. But in a role play task, you are supposed to speak only in a patient-friendly language. Otherwise, your communication with the patient is going to be a big nothing. All right. And the teaching task is somewhere, I would say 70% of you speaking as a doctor, and 30% you have to a bit down to the junior colleague and explain to him or her, teach her in a friendly language. It's not necessary for you to use all the patient-friendly language, no, because he's a fellow colleague. He's a doctor himself. He's just a junior colleague. But at the same time, you cannot bombard him or her with all your knowledge. So that means that you're trying to dominate the scenario. So that might pull your communication with the colleague. So when I say, may I check your name and age? So that means that I am empowering you. I'm saying that I'm saying that you and me are the same, but I'm a person, a doctor, who's going to tell you certain things about your health and your condition and treatment options in a patient-friendly language, so that I'm empowering you to make a shared decision plan, and we are together to make this. So that is what is the meaning of me. Check your name means I've already read the candidate instruction. I'm aware of that. I'm just cross-checking that. If you say, can I confirm, that means that you are dominating her. You are taking an upper hand in the conversation. So you're not empowering your patient. So that will pull your communication down. So please use these particular words by heart. May I check your name and age, please? Ask her what would be like to be called. Her name would be given as Sarah Williams. So you just cannot say Sarah, Sarah, Sarah everywhere. You please ask her what she would like to be called. So please ask these specific words. What would you like to be called, and not how would you like to be called? Again, I'm not teaching you grammar, guys, but this is communication. Believe me, GMC is very, very particular, and GMC has got a definite set of code and ethics for the doctors to practice. And GMC, General Medical Council, has got good practice, good practice policies and protocols and rules. Supposed to be rules where each and every doctor is having a GMC is supposed to license. The GMC is supposed to practice in that particular way. Okay. So what would you like to be called? Not what would you like to be addressed, right? And then she will say Sarah or Sarah Williams or Williams, Mrs. Williams, whatever her name she wants to be addressed. You will be, so my name is Guna Krishnaveni. So you can call me Guna, you can call me Krishna, you can call me Veni, you can call me, but my choice is I would like myself to be called as Guna, and you have to call me by that name. So that is communication skills, right? So you will be talking in that particular language that the patient is happy to communicate with you, right? Not you happy to communicate with the patient. So believe me, this is the other way around. So please ask these specific questions. What would you like to be called? Then she will say Sarah, or she will say Maria, whatever is her name. Then say, thanks, Sarah. Please call me Guda. Or please call me Tahira. Or please call me Aisha. Please call me Arya. Right? So that means you're again empowering the patient, saying that I'm also part of this communication. So we are together in this discussion. We are together in this consultation. And I'm just a medical personnel to share my knowledge with you and tell you to help you, to share my knowledge and help you in treating you or giving you the various options or whatever her discussion is, her consultation is based on, whatever the purpose of to fulfill the purpose of today's consultation. So this is what is called as empowering patient. Unless and until you're going to do this, it may not be an impressive start, but believe me, if you're going to do this, it's going to be a damn impressive start. So I always tell my candidates, the first 2 minutes, the last 30 seconds is what maximum attention span of your examiner is going to be. The first 2 minutes, the first minute is your introduction, the confirmation of purpose, your agenda fixing. The second 1 minute is your history of presenting illness. The third, and then you carry on and on. The last 30 seconds is how you're going to close the station, right? So this is where they will have the maximum attention span. This is where you'll have to really perform well, perform well. Remember, not answer well, it is perform well, so that you'll have an impressive start and a very good close of the station, and you will be easily having a smooth sail towards clearing this exam. Each and every task counts. All of these 14 tasks, each and every task demands you or is worth of all your attention, all your concentration, and all your focusedness to clear each and every task individually, so that you will come out not with just a pass, but with very, very good scores. And that's why we've been training so far our candidates to get the top scores from us. Right. So I respect all my fellow mentors. my colleagues who've been working day and hard for months, for weeks, for years together in, and everyone is, I would say, a shining star is going to, who's there, is actually shining his or her light in her own way, his or her own way to help you all to clear this exam, the last leg of the MSUG, that is the part 3 exam. Okay, so I do respect, have a lot of love and respect and friendliness to all my fellow colleague mentors, as well as I do put in my own thoughts to train up each and every individual who joins with me in the course, because that's why I conduct only limited batches and limited number of candidates. We don't believe in master teaching, conducting mass classrooms, batches after batches. I'm sorry, I'm not a person for that. We are not here in smart, but we teach in a smart way, and that's why we choose very minimal candidates, right? Right. So having spoken that, so after you have introduced yourself, suppose the child is going to have some pain, some vomiting, some breathlessness, some physical discomfort. Please settle that first. Not only the physical discomfort and emotions as well. Suppose you're going to see a crying patient who's lost a baby, so be empathetic to her. Start with this impressive start. Offer her condolences. Offer her bereavement counselor services, and help her to open up. But if you go on starting and shooting your questions, believe me, she will not open your mouth for all the 10 minutes. She's going to just keep tight-lipped, because if you think that you're a doctor and she is the one to answer you, believe me, it will not happen. So address her physical discomfort as well as her emotions. Settle with the physical compliance as well as her emotions well in the beginning, so that she will be able to cooperate with you with the rest of the task, and she's going to lead you to success. Befriend her. Try to become a friend of her. Speak to her in an empathetic way. Think a fellow human being is sitting in front of you with some pains and discomfort. She has lost a baby. She's got a bad third-degree tear. She was sutured 4 days ago, and she's in pains. She's constipation. Just be empathic. Empathy always, automatically, your empathy will flow from your heart. Okay. So if this patient is in pain or vomiting or breathlessness, please settle the patient. Give a pain relief. Give a medicine for vomiting. After ruling out allergies, give her oxygen if she's breathless. Pause for 10 seconds and then seek permission to continue. You can just say, you cannot just say, you cannot just trust her things. Okay, take this oxygen, take this medication now. Come on, answer my questions. You can never ask to do that. So pause for 10 seconds. Believe me, they know it's an exam. They are not real patients. They are only role players. You know it's an exam. They know it's an exam. The examiners know it's an exam. So they will not waste your time. But if you do not seek a permission to continue, your communication will be down very badly. So this is where candidates tend to lose the exam, especially for those candidates who work in the overseas, who are not, unfortunately or fortunately, or not worked in the UK, who are not aware of the working conditions there, who are not aware of the working style there. If they tend to, this is where they try to lose marks in the communication skills, and they do just lose by 1 mark or 2 marks, because they totally do not know how to communicate with you. With the patient, sorry, how to communicate with the patient, and they tend to lose marks. So this is where the lacuna develops, right? So do not say congratulations, especially if something there's an early pregnancy complication, there's a loss, there's an IUFD, in any other station, some complications, something has happened. So please do not say congratulations. If she's with early pregnancy complications like ectopic or threatened miscarriage or molar pregnancy or whatever it is. First thing called is agenda. So in the beginning, I told you the agenda of the meeting is we'll be talking about the methodology of the exam and the content of the exam. So this is how any meeting should have an agenda, a purpose. Time is precious for you and me. So we are here to discuss for a discussion. So we have to have an agenda. So same like that, every task has got an agenda. Every role player, you have to fix an agenda. So you have to just say that I can see from the notes given here or from the GP letter that you have this condition and you have come for this particular purpose. Am I right? So that means all these things will be given you your candidate instructions for the beginners. Will be when you start doing the task, we'll be able to understand what I mean by this, right? So this is all these instructions will be given in your candidate instructions, which you've already made a note, and then you'll be just reconfirming with her that this is why she has come and meet you. And it is not sufficient only that you have to just check her what are concerns and expectations from consultation, from that particular day's consultation. See, for example, if I'm coming to you, I'm 7 weeks pregnant. I just got a bit of spotting since last night, and I am here to just discuss about to just there was a scan was taken, but for the past 2 weeks I have been having retching and vomiting, and then especially the last 3 days I couldn't even drink a glass of water or a glass of juice. That is my condition. In that case, what you could have done a scan for me. Your colleague would have addressed for a scan, wait for a scan, and you are here to discuss. I'm here to discuss with you, right? So in that case, in that case, if your agenda will be like you will be concentrating on, oh my God, this is the scan shows that it's a molar pregnancy. Let us take for example. Then you'll be thinking, oh, this is a molar pregnancy. So I'll have to talk about molar pregnancy, about the evacuation, about the follow-up, about the registration with the regional centers, about the follow-up, about no, she should not use any copper that is a copper T or any interactive contraceptive device because the uterus is fragile now. I shouldn't talk about. I should be talking about recurrence rate. I should be talking about the spacing. She has to use some all sort of stuff will be coming to your mind. Will be going on and on and on. But you have never addressed my concerns, my dear. So that's why people tend to miss the bus. My concern is I've been vomiting. Poor little me. I do not know about your molar pregnancy and about your beta HCG follow-up and about your regional trophoblastic regional centers. I don't know. I'm a poor little woman who just has come vomiting, excessive vomiting. I'm not able to eat things, I'm not able to drink a glass of juice also. What the hell life is. My quality of life is compromised. So if you're not going to address my concerns, if you're not going to address my expectations because I need something, some fluids, I need something anti-sickness medication, I need some comfort words, and then you take whatever you want, I'll be able to accept. But in the event, in the beginning, if you're going to do that, you're going to absolutely clear. But at least, even if you don't remember to do in the beginning, please say at the. So now, right now, I'll be admitting you. I'll be starting a new IV fluids. I'll be sending by putting a plastic cannula in your arm, and I'll be just sending you for some tests, blood for some tests. We'll be giving you some anti-sickness medication. So once you feel better, we'll be doing this for you. Okay. So unless and until you're going to address what is there in my mind, what are my concerns and expectations, you're not going to clear this task. So that is what we call as concerns and expectations. There's something called as ICE, ICE, ideas, concerns, and expectations. So ideas is just to know what could be the reason for this particular person's condition. Molar pregnancy, let us take for example. Or let us take, is there anything, why this patient has incurred this particular condition? Why this patient has, like for example, let us take ectopic. Does this particular patient had any sexual site infections in the past? Was this patient on any copper IUCD before? It could be the reason. Is there any supportive evidence? Any scan report is there? Any hormone beta HCG reports are there? So what could be that be? What could be the reason? So that is called as ideas, as well as you explore her thoughts when you comment on the diagnosis. So Sarah, you seem to have what is called a smaller pregnancy. So do you have any idea about that? So just called as exploring her ideas. So that is called as ICE. So she will come out with whatever any her concerns and expectations from that particular day's consultation, what she wants or what she expects from you and your consultation. Right. So before addressing your concerns, they say, is it okay to ask a few details from you by asking you some questions at the end of which I might have to examine you in the presence of a chaperone. So always examining her in the presence of a chaperone is a patient safety as well as for your safety. So even if it is a a female doctor or a male doctor, irrespective of the gender of the doctor. So every doctor is supposed to have a chaperone. There'll be a chaperone provided to you, a nurse, a midwife, it could be anyone who will be, doing certain things like recording blood pressure or weight to height ratio, or making her lie on the couch, just like the chaperones that you have in your own setup. This a chaperone is a must for the patient safety. So the presence of a chaperone, if you allow me, run a few tests if needed, and come to a diagnosis, and we can make a safe, agreeable, shared management plan. Remember, it's going to be a shared management plan, and it is not something like you decide on something, you dictate to the patient that I want you to do this operation, I want you to take this medication, nothing of that sort. So that may be whatever someone practices or someone does not practice. So we will not talk about that. That's not our agenda today. So we will be talking only about the RCOG standards. So you're here to make, along with the patient, a shared management plan that is going to be agreeable for her, as well as that is going to be safe, and that is going to help her come out of this particular condition or a sickness or whatever it may be. So then ask her, how does that sound? So please ask with start with open questions. Could you tell me more details about this pregnancy? So don't ask an yes or no type of questions. Don't ask closed questions. Closed questions are the ones where, if, like for example, as I told you previously in the beginning, these are professional artists, professional actors who are being given a different set of scripts and emotions to enact, right? So there'll be some details which is given in the script, and whenever you ask an open question, she is going to come out with whatever is given in the script. In the event of you not getting some information, you'll have to ask those questions, and never ever should be like this or that. So if it's going to be this or that, yes or no type, she's going to say yes or no, or she's going to just answer to the question. So, Sarah, do you have children? Yes, doctor, I have 2 children. But Sarah will not tell you about the miscarriage. Sarah has already had 2 miscarriages. So that means she is now 5th gravidae. But if you're going to say, Sarah, could you tell me how many kids you have? She's going to just say 2. But if you're going to ask Sarah, Sarah, could you tell me about your past pregnancies? She's going to say, yes, doctor, I had two babies and had 2 miscarriages. The first one was a boy, then was a miscarriage. The second one was a girl, and the fourth was a miscarriage. So that should be your knack of information gathering in a quick and a smart way instead of wasting time and asking about it. It's not an interview, as I told you. It's not an interview. It's not a question and answer session. It's not a quiz program. You're going to ask her questions, and she's going to answer you. No, it's a totally interactive exam. So please communicate in that particular language to her. So please ask set of open questions. Could you tell me more details about the compliance? Start with open questions. If you need some more information, just ask those questions to know whatever you want to know. Right, information gathering, my dears, it is 3 things to put together: your history, your examination, and the investigation. All 3 things come under information gathering. It is just not mere history taking. So start with the history, start with the open question, start with the history of presenting illness, my dear. As I told you, it's a circuit exam. There are 14 candidates. Out of that, if you want to excel, you have to be excellent in eliciting the history of presenting illness in detail. So that's going to be a very important thing which is going to differentiate you from the rest of the other 13 candidates, and that's going to help you score well. And that is where you'll have to stand. You have to have an impressive start. The second minute, as I told you, the first minute is over. The second minute, we are entering to the second minute. So believe me, friends, all these things, how does that sound? Till this is going to be your 50 to 55 seconds. Believe me, it will come by practice. The information gathering is a history. Start with history of presenting illness. So this is the basic medical schooling, 3rd year medical school teaching. Ask her details about the compliance. Ask her anything about the pain, the bleeding, and early pregnancy. Never forget to ask about water works and bowel opening. Ask about the details of the current pregnancy. Please ask open questions about the parity. She'll come up with whatever is given in her script. If she doesn't, then ask her close questions. Ask her previous obstetric history, especially in all the cases, all the obstetric casts. Please ask the obstetric history. So obstetric history should include previous pregnancies, the mode of delivery, any similar complaints. What about the recovery of the previous deliveries? How about what are her thoughts about future pregnancy plans? So This may not be suitable for all the tasks, but for a few tasks. Ask the gynec history in detail. So ask about the periods, ask about any previous contraception, ask about cervical screening, and all the cases of pregnancy age specific. So for a 19-year-old girl, you're going to ask, could you tell me about your cervical screening? So what I mean by cervical screening, we don't call it as cervical smears anymore. We call it cervical screening, right? So that's going to be absurd. So that means you lack situational awareness. So it should be according to the age and according to their health condition. Some like for example, HIV woman is coming to you. That means she could have had an annual smear. So you have to elicit such history. So depending on high risk cases like HIV or renal transplant, so something called a signposting for the sexual history that we'll be talking about. Sexual history is a sensitive history for you, me, and everyone else in the world. So ask about signposting. I'm sorry, I need to ask you some personal intrusive questions. Will that be okay, Sarah? Because those informations are needed for our management plan. Will that be okay? Please seek a permission. So, or you can say, Sarah, I'd like to ask you personal intrusive questions, if that is okay with you, because these details will help us in our management plan. Will that be okay? Yeah. So seek a permission. That's called a signposting. And ask two clear, specific questions. Sarah, could you tell me more details about your relationship? Or you can ask me, could you tell me, are you stable in your relationship? Right? So simple two questions are going to bring out all the necessary information that is in pocket, that is there in the script. Okay. So are you clear? Are you stable in your relationship? She's going to say yes or no. So if she's going to say yes, then go to the next question. Have you or your partner been ever treated for any sexually shared infections in the past? So all these will give you the total history. Suppose if she says, no, this is my second partner, then ask, could you tell me more details about your previous relationships? So whatever is there in the script, she's going to answer to you. So the third question will be, could you tell me whether you or your partners have you ever been treated for any sexually shared infections in the past? So all these 2 or 3 questions is going to elicit. So believe me, this could be done within 45 seconds. We're asking about the medical history, any medications she's taking, any allergies. Very, very important. Patient safety, you have to ask. So this particular word, allergy, this particular, information, allergy is important for you in all the 14 tasks. So allergies. So don't some repeat candidates I've seen they're telling allergy to medicines, allergy to food, allergy to this, allergy to no, don't ask such questions. Just simply ask allergies. Allergies to do you have any Sarah, any known allergies? But in case of you have to ask some specific questions. For example, suppose if you're going to give copper IUD for a patient, something like an emergency contraception, you have to ask, Sarah, do you have any allergies, especially to copper? Suppose if you're going to say, let us say, for example, if you're going to say HRT to a woman, hormone replacement therapy for some perimenopausal symptoms, you're going to ask her whether she's allergic to, whether she's intolerant to lactose. In that case, because that contains some lactose preparations which may not be suitable for a person who's got some lactose intolerance, so there you will elicit. But not each and every patient. You have got allergy to medicines, you've got allergy to this, you've got allergy to that. It's a sheer waste of time. So just ask any known allergies, or do you have any allergies? That might suffice more than sufficient, but be specific. So we'll be teaching you generic templates, but according to the, as I told you, it's customized, tailor-made knowledge for that particular task and for that particular as the role play demands. Then you'll take details about the previous surgeries. We don't bother about some neurosurgeries or some fracture surgeries. We are pertaining ourselves to any surgeries in the pelvis or the tummy or the down below. Ask a blood group, very, very important patient safety point. And there's something called the Jehovah's Witness, where they are staunch religious believers. They do not take any blood or blood products from outside. So these are called a Jehovah's Witness. So if someone is a Jehovah's Witness, you'll have to rule out whether she's a Jehovah's Witness. And in the event of her, she being a Jehovah's Witness, it has to be recorded in the file, and the team has to be updated about that. So a Jehovah's Witness. So ask a blood group and type, and any reservations for transfusions or any restrictions for transfusion. Personal history. Weight to height ratio, very important. So BMI is a jargon, so everybody, each and every English woman might know what is a BMI, but still, RCVG expect you to use the term weight to height ratio. Ask about smoking and alcohol. It could be their lifestyle, but when you ask about recreational drugs, just say, I'm sorry, I would like to know whether you used any recreational drugs, or you can just simply say, pardon me for asking, or excuse me for asking any recreational drugs. As the social habits of the occupation, very very important, but it has got so much implications. She could be a commercial sex worker who is developed HIV in pregnancy. She could be a commercial sex worker. She has been exposed to repeated, sexually shared infections. We never know. She could be a primary school teacher, a nursery teacher who has contracted chickenpox from her kids at the school. So please, she could not be doing any job. She has to depend on her partner. So we don't use the term husband, so we use the term partner. So partner for her livelihood, for her for her basic essentialities. So that could be one of the reasons that she's being subject to domestic violence. We never know. So please ask her occupation and ask her whom does she live with. Okay. So, whom do you live with? She will say her partner. So, do you feel safe and well supported at home? So, please do not ask generic questions like, how is everything at home? How is your supportive? So, suppose if you come to me and ask, Guna, so how is everything at home? I'm meeting you for the first time. I'll say everything is fine. Even if I have some problems, I will not reveal to you. And you can never ask me, is your partner supportive? I'll get offended. Why does this doctor is asking me what is that is bothering for her, whether my partner is supportive or not? Who the hell is she to ask me? So that could be my feeling. So please ask what you want. You want her to be safe and well supported. So please ask only those questions. Do you feel safe and well supported at home? So the answer is going to be yes or no, and so that will give you a clarification whether this particular woman has been subjected to domestic violence, whether she's being under threat, whether she's being intimidated, whether she's being under force, or whether she's safe. So you want her to be safe at home. You want her to be well supported at home. So please ask these questions. Do you feel safe and well supported at home? Ask her any family history, any specific family history, or it could be clots, it could be diabetes, it could be hypertension, it could be anything. It could be some congenital bleeding disorder, it could be anything under the sun. So please ask her any specific family history of concern, and ask her mental health, how she feels in the past 4 weeks, because mental health is very, very important, because uh, globally, most of the women tend to have a lot of issues. They get into a lot of issues, working women at home. I mean to say the homemakers or whatever you call it as. So everybody's under stress. Everybody's got sort of mental health, not a mental health issue per se, but some upset, some depressive symptoms, so something which doesn't work out good for them. So the past 4 weeks, just ask her, has she ever felt low or hopeless or depressed? Just a lot of depression. And try to summarize all these information that you've collected. So believe me, friends, all these, whatever I've spoken so long for more than 25 minutes, we'll have to speak to you in 3 to 3.5 minutes and nothing more than that. So maximum 4 to 4.5 minutes, including your information, introduction and agenda fixing. All right. So try to summarize. So what are the positive points? So I can see that now you're Sarah Williams and you're 7 weeks pregnant. You've come with spotting and you've done some scare tests have been done for you, and you're here to discuss the reports. And you have O negative blood group. Your father has had a DVT last year. Huh? So whatever positive points she's going to say, try to summarize. RCVG expects you to summarize because it's not compulsory, but still you are a safe doctor. You have really made an active listening. You actively listen to your patient, your role player, and jotted on all the points that she's saying, and then you are taking all the pains to reconfirm that these are the information. So I'd like to summarize. So you are this. Would you like to add any more information? So if at all, if anything is there in the script, it is for your good. So if anything is there in the script, she's going to come up. Yes, doctor, 2 days back before I traveled to Zambia, I was bitten by a mosquito, something she's going to come up. So if you don't ask her, she's not going to tell you. If at all, if there is anything else, which is left over in her script. Right. So that is the importance of summarizing things. Then examination. So examination is always after her consent. So you can never touch a patient without consent. Even if it's just a BMI or a blood pressure, you can never do things without the consent. I would like to examine you in the presence of a chaperone. Will that be okay, Sarah? I would like to, then you should justify what you're going to do. It's not just can just say, take a consent and do whatever you want. You have to just justify. The nurse chaperone will recording your blood pressure and weight to head tissue. I'll be having a feel of the tummy. To look for what? To look for any painful areas, any palpable mass, or any to look for how the baby is doing or how John the baby is doing, or whatever you want to say. So please justify. As I told you in the beginning, it's an exam of justification. You need to justify yourself to the role player, to the examiner, to your fellow colleague whom you're teaching. So you need to justify yourself why you're doing this. The same way, you have to respect the patient and justify to her, I would like to do a tummy examination for you, and I'd like to see this. I'd like to have a look at the down below to check from where the bleeding is coming. Just put a metallic instrument called testospiculum to just check if there is from exactly from where the bleeding is coming, or how the the episodic, or how you can just say anything else that you want to say. You have to just have a look of everything as it goes. So you have to explain you're obliged to explain to the patient, and without that, this may not be a passing station. So please, member friends, so information gathering includes history, examination, and investigation. So generally, even so, if the information investigations are giving, you're supposed to confirm the name and the date of birth and the NHS ID. So don't leave the NHS ID like 1, 2, 3, 4, 5, whatever is given. Just say, I've confirm your name and date of birth and NHS ID, and this belongs to you. And then directly say whatever is given in the information, in the reports. But sometimes you might have to order her some extra tests, some UPTs, some hormones tests, something will be there, some ultrasound scan from down below. So some would be there. So you'll have to just talk on that. Otherwise, just say that you already confirmed you confirmed the name and the date of birth and then NHS ID. There's something called as breaking bad news. This today should not be, we will not be talking about what is breaking bad news, because this is an important aspect. We need some time to discuss about it. We are talking about the just general template. Explain diagnosis in the patient-friendly language, check her understanding, and explore whether she's got any idea, because she would have already had an ectopic pregnancy. This might be an ectopic pregnancy. Again, she knows what's an ectopic, so you don't waste time. So just ask her, have you aware of this, or do you know this condition, or have you heard about this, or check her understanding, okay? And then if she says that she doesn't know, then start explaining. Otherwise, don't waste your time. Right. Then coming to your applied clinical knowledge. Yeah, the management, please, according to the diagnosis, involve, as I told you, communication with a colleague. So you need to involve your consultant. You need to have your MDT, your multidisciplinary team, including your doctors, your consultant, your super specialist, your specialist, your colleagues, your own colleagues, your juniors, in the sense like it could be a midwife, it could be an anesthetist, it could be a hematologist, it could be a endocrinologist. So it could be anything that way. It could be a pediatrician, it could be a neonatologist. So all that is part of your team, including your specialist midwife, your specialist nurse, your counselor, your dietitian, your physiotherapist, your occupational therapist. So all these could be part of your team, depending upon your task. So always the communication with a colleague, as I told you in the beginning, it's a common platform. You're a middle grade doctor, where you'll be interacting with your consultant, with your top level, higher doctors, your bosses, as well as you'll be interacting with your junior colleagues. So this is going to be a teamwork, and so you need to communicate with your colleagues. So that is what this importance of communication with the colleagues. Try to involve as much of colleagues as possible as per the station. And then always start from the basic and the conservative options and go to the highest. You might know very well that if the beta HCG is going to be more than 5,000, and if you see a live ectopic pregnancy, you have to just go and do a salpingo-oophorectomy. But if you're just going to say a salpingo-oophorectomy, two things will be going down. One is the applied clinical knowledge. Second thing is your communication, because you don't bother to explain to her what are the necessary options, and you don't have time to explain to her the options and say and seek her ideas and get her, make her get what you're saying, and allow her time and space to reply you back with whatever her choice. So you have to start with, like, for example, you can see there are three particular options for this condition. What we call it as basic, what we call it as like expectant, where we allow the nature to take its course. But unfortunately, that will not be the option for you, because you have the pregnancy is a little advanced with a heartbeat. The next is the medical option where we give an injection per methotrexate, but that again may not be a suitable option because your pregnancy is a little advanced and we can see you see the heartbeat of the baby. So the best option and the last option for the last but the best option for you is the surgical option where we do this for you and this for you. So unless and until you're going to say that, it may not be a complete scenario. You'll not be able to clear certain domains. Okay. So always give a start with the basic and the conservative options and then go to the highest. Explain each and every option shortly in a patient-friendly language, telling about the pros and the cons and the procedures, if at all, if it is necessary. Please give information in chunks. We mean to say give some information, take a pause, check and understanding. Am I clear so far? Do you have any questions so far? Are you with me? Am I making sense? If you don't ask, are you following me? Are you listening to me? That means you're dominating the patient. Just make sure that whether you are clear to the patient, whether you are able to make the patient understand, and whether it's not that she has to follow you or she has to understand you. Okay, so that should be a communication skill. So please ask questions like that. Am I clear so far? Do you want me to repeat anything, or do you have any questions, or am I making sense? Such questions would be the best way of communication. So address the patient. So whatever, so I will be talking on and on and on and on about pregnancy, but if you don't address my vomiting, my nausea, vomiting, and my nausea, vomiting, my hyperemesis, then it's going to be a failing station. So please address my concerns there. And ask any questions. Do you have any questions for me, Sarah? So Sarah might, if at all, Sarah's got some questions, then it's good. She's going to come out with that. Otherwise, if she says no questions, I'm happy with what we explained. So that means that you are clear and sail through. And then always do a proper closure. Suppose you need to admit her or you would have a follow-up appointment, do that. Give her a safety advice if at all, if you're going to send her back from your OPD. Send her, give her red flag signs. Suppose she's going to, for example, if you say a patient with a is coming to the early pregnancy unit, a miscarriage or something, you have to just say, if at all, if you're going to get more bleeding or more pain, or you got any shoulder tip pain, or if you feel dizzy, please come back to us. Okay. So see the red flag signs. And when you say the red flag signs, always give my 24/7 contact number. I would like to give my 24/7 contact number, Sarah. So in the event of you getting any bleeding or any pain or severe tummy pain or you throw up, so please come to us. Okay. So that should be a 24/7 contact number. And always try to write back to the GP or to the community midwife, keep them in the loop, and they are very essential part of the treatment aspect. So that is your communication with the colleague. And give a patient information leaflet. So this is nothing but a leaflet where all the medical conditions has been explained in a patient-friendly language, the treatment options, everything has been expressed in a patient-friendly language. And there'll be some web links for the support groups. So we have so many groups, the roundsupport.org. We have the spine group and so many other groups. So towards the examination, we'll be giving you a list of groups. Don't worry. So once you finish the exam, we'll be doing all that for you. So support groups, we'll be giving the web links and thank her for the time. So all this, my friends, you'll have to finish in these necessary 10 minutes. So that we have come to the end of this template. So for the beginners, for the newcomers, I'll be telling what is we meant by patient information leaflet. All right, so we go to the RCG website. So let me focus my slides. So let me so this is going to be the your RCG website, and then you'll be you just have to go for the public, the home page, and there you'll be browsing some information. So you have to just go to browse all the patient information leaflets, and there you'll be having a list of leaflets. Okay, you'll be given a list of leaflets. For example, if there's something called as assisted vaginal birth. So again, if you have to just go, let's take an example. So just go for the print version. So you want to listen to a podcast, you can listen, or you want to take a printout, you can take out, or you just want to study online. I mean, in the laptop with the phones, it's absolutely up to you. So this is going to be information. So all these patient-friendly languages will be given. The same thing that you studied in the guideline, almost the same, but it will be in a totally different language. So for the beginners, kindly read at least 2 to 3 patient information leaflets as and when you do the tasks. So again, this for the public information. So this is the patient information leaflets, and this is the A to Z of the medical terms. So believe me, for abdomen, you'll be saying the tummy area from the lip, lower ribs to the pelvis, you can just say tummy area. So for acute, we use the term sudden and severe. For anesthesia, we say it's a medical way of relieving pain. Anesthetist is the doctor trained in anesthetics, such things we'll be talking. So biopsy is a small tissue sample, okay? We call it tissue sample test or tissue sample testing, okay? We don't say it's biopsy, it's a jargon. The jargon means it's a medical terminology which the patient will not be understanding, all right? So cancer is a research cell. So please take at least 10 information, 10 words of this and study by heart the medical terms as well as the concerned layman terms. Okay, so this is what is given by patient information leaflet. So guys, are you clear so far with this long talk, or you want me to repeat anything, or do I make sense? Guys, I'm not getting
Yes, it's
answers.
clear.
Clear? Thank you, my dear.
Ma'am.
Thank you, my dear.
Yes,
Thank
it's
you.
clear, ma'am.
Thank you. So let us continue with the tasks. So Tahira, are you there, Tahira?
Yes, I am here.
Yeah, okay. All right, so let us go to task number 1. Right. Give me 1 minute. Okay, over my task. All right. 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 Please tell me if my slide is visible and my task is visible. Tahira, are you ready, my dear?
Yes,
Right. So please,
yes,
yeah. So please see if I can see my timer and you can see my task. Right. Is it available?
yes. Start. I will start now.
Yeah, I'll be starting your 2 minutes. Before that, if you want to type anything in the in the 2 minutes time, because this has got 2 slides, you let me know when I should scroll the next slide. Second thing is you have to you can type whatever you want. The 2 minutes you can make a notepad, and you can, if you want, you can share it on the group, or you can send personal message to me. I mean in the chat, if you go to the chat box, there's an option to say chat is to everyone or to any person. So for that, you can just send the thing to me that says Smart Mentor. Okay, so that would be a better thing, right? So your 2 minutes starts, Tahira, now.
Okay. Yes, next slide, please. Yeah, next slide. Is there any other slide, or this is the all?
Yeah, there are only 2 slides, my dear. First and the second one.
Can you show me the next slide, please?
Yeah, please. Your 10 minutes starts now, my dear.
Hello, I am Dr. Tahira, one of the doctor covering the antenatal clinic today. May I check your name and age, please?
Hello, doctor. I'm Valerie Richards, and I'm 40.
How can I address you?
Please call me Mrs. Richards.
Thank you, Richard. Richard, my midwife called me to discuss the result of the test with you. Am I right?
Well, yeah, you're right.
So, Valeria, can I ask you a couple of questions to know more about you? And then, so that because I am meeting you with the first time, after that I will discuss your result and your further care plan, and I will write back to your GP and I will give you patient information reflect. How does it sound to you?
Yeah, that's absolutely fine, doctor.
Can you tell me a little bit more about your pregnancy in detail?
Well, doctor, it is my first pregnancy, and it's natural pregnancy, and it's a planned natural pregnancy, and we are very happy to have this pregnancy. And I'm now around 11 weeks, and everything has been fine except that I threw up a couple of times, and I was given some anti-sickness medication, and I'm on folic acid, doctor, and some pregnancy vitamins have been given to me.
Is there any nausea and vomiting?
Yeah, I threw up a couple of times, and I was given some anti-sickness medication for that.
Okay. May I know, have you ever been pregnant before?
No, doctor, it is my first pregnancy.
Okay, and when was your last period?
Approximately 11 weeks before.
Okay. Do you have any other medical issue for which you are calling your GP?
No,
Any family history which is concerning you, like diabetes, high blood pressure,
no,
any abnormal child in the family,
no, doctor,
any operation done your tummy and down below?
no.
Except folic acid, are you taking any other medicine?
Yeah, some pregnancy vitamins also given to me.
Okay. Any allergies?
No.
Do you smoke?
I was smoking, doctor, but once I become pregnant, I stopped.
It's good. Do you drink alcohol?
No, I don't.
Any recreational drug?
No,
Pardon.
no,
How is
doctor.
sport at home?
Yeah,
Are you
yeah, my partner is very friendly and supportive.
okay? Nice to hear this. Do you feel depressed, low, and hopeless in the last 4 weeks?
No, doctor.
Do you know your weight and height ratio?
Yeah, it is 28.
And about your blood group?
A positive.
Any reservation about the blood and blood product?
No, doctor.
Are you update with your cervical screening program?
Yeah.
Good. Do you feel? Thank you very much for the information you shared with me. Is there any other thing important you want to add?
No.
Okay. So, coming to your concern about the result of the test, do you have some idea or someone who explained you about the results before?
No.
I will first confirm your name, age, and NHS number that these test result belong to you. So
Okay.
coming to the result, you did the ultrasound and you did some of the blood tests.
Yeah.
Actually, there is some concern regarding these test results. The result of the ultrasound shows that you are pregnant. Your pregnancy is 12 weeks and 4 days, and you are pregnant. You have the single baby. The fluid we are usually checking at the back of the neck of the baby. We called it anti-scan, and this is a little bit higher, that is 6 millimeter. And the result of the blood test, these are the hormones which we are taking, which we are doing on the blood of the patients. The result, one is known as the pregnancy plasma associated plasma protein, and one is the beta hCG. These all tests will be on the higher side. So regarding on the basis of your age and also the result of ultrasonography and the result of these blood tests, we calculate the risk of trisomy or risk of Down syndrome. I am sorry to tell you the risk is higher, that is 1 in 4. Am I clear so far?
Oh, okay, doctor. So what does that mean? Is my baby having Down syndrome?
It's not like that. It means that out of the 4 women, one woman will be found to be have the Down syndrome baby. This is a diagnosis. This is a screening test. So we have to be do more tests in order to make sure that how's your baby and you are one of them or not.
Mm-hmm.
Am I clear?
Uh-huh.
And the
Okay.
result of the other abnormality, that is the trisomy 13 and 18, is the low risk, but the risk of Down syndrome is higher. So what we will do, I will refer you to the specialist doctor in the fetal medicine center.
Mm-hmm.
They will discuss with you the further test. That is the diagnostic test. Do you want me to continue and tell me in detail about that?
Yeah, doctor, that would be better.
Yeah, so the doctor will offer you the needle test. That is, they will numb the area of the tummy and they will take the fluid, either the fluid from the around the baby or take the tissue of the sample of the afterbirth and let it to check in the laboratory. This test will take about 3 days for the result to come, and there is a slightly increased risk of the miscarry. That is 1 in 200 people miscarry. When the result will come, they will call you and will discuss with you about that your baby will be affected by Down syndrome or not.
Uh-huh.
Am I clear?
Yeah, you're clear, doctor.
Uh, yeah, this result will be ready within the 3 working days, but there is another test which will be done to check other abnormality in the genetic makeup. It will take about the 2 weeks for the complete test to come back. So, what do you think about that?
Uh-huh. Okay, doctor.
So, so may I know what's your position? Suppose if your baby is found to be having the Down syndrome, then it will be your choice. Either you want to continue the pregnancy or you want to terminate the pregnancy. Whatever decision you will make, we will fully help you and support you in doing so. So that.
Uh-huh. Okay. Okay.
Uh, and do you want me to give more, some little bit more information about the Down syndrome?
Okay, doctor, tell me.
In the Down syndrome, there is the all individuals have 46 pair of the chromosome, and one pair is the sex chromosome, and 23 other chromosome. So, in case of the Down syndrome, there is one extra copy at the chromosome number 21. So they have the 3 copy of the chromosome number 21. These babies they have some problem in the heart and some problem, they have some learning disability and some intellectual disability, but it's not for sure to tell that how much disability the baby have until and unless the baby will be born. Am I
Mm-hmm.
clear?
Mm-hmm. Okay.
And I will also put in touch with the charity and group of the Down syndrome and trisomies 21, where you will come across with the thinking of the other parents that how they will make decision and how they will go further about the thinking have the baby about the Down syndrome. But
Mm-hmm.
it's not necessarily that you are one of them. There is only 1 in 4 chance that out of the 4, one baby could be the Down syndrome. Do you have any question?
No.
After that, if you want to continue the pregnancy, your care will be in the multidisciplinary team, that the group of the specialist doctor. We will put in touch with the baby doctor as well. He will come and will discuss with you about the appearance of the Down syndrome, how they will be look like, and
Mm-hmm.
also the special support group and our the consultant doctor as well and specialist midwife. And your care will be further continue and you will be given the detailed scan of the baby at 20 week of the pregnancy in order to make sure that how is the baby is developing. And then you will be seen every 4 weekly, and we will start the growth scanning of the baby from 26 to 28 week every 4 weekly till 36 week of the pregnancy. At each visit we will check your blood pressure, your protein in the urine, and at 36 week we will discuss about the mode of birth with
Uh-huh.
you. With our doctor, who will give you pain relief, and our consultant obstetrician. Am I clear?
Yes, doctor.
And you will be delivered in the consultant unit. Your baby will be continuously monitored, and baby will be seen by the baby doctor afterwards. And you will be given full support and help. And after the birth, we will give you stocking and risk assessment part. The clot will be assessed and blood thinning agent and special stocking will be given accordingly, and you can breastfeed your baby. And so, any questions so far?
No, doctor.
My time finish?
Yeah, your time is finished. You want anything to say?
I will give you this question information leaflet. You will go through it. So yeah, you will still have the time. So don't worry. Discuss with your partner and family member. Whatever you will be deciding, we will fully help you and support you. Do you have any question?
No, doctor.
Thank you very much.
Thank you. Thank you, Tahira. Good strategy. Well, Tahira, so tell me your reflection. So, what do you think went on well? What do you think you could have done better?
I should discuss some other tests as well. That is the NIP. But this is still a diagnostic test. Oh, sorry, the screening test, not a diagnostic. And I don't know because I am so much confused. Maybe I have made a lot of mistakes.
No worries. Well, yeah, as you correctly told, you should have talked about the NIPT, the NIT. And my dear, you are labeled Valerie that she's going to be a Down's mother, and you went on and on and on and on and on about the antepartum, intrapartum, support in labor, and so many things, my dear. This is the station doesn't demand that. The station is told the task which is given to you has indicated that this is a 40-year-old primary woman. She has come to you with the results, with the combined testicles. So you have to just talk to her. What is the next step in her management, right? So that is, you have to refer her to the FMU, and you have to give her the option about the series of the amniocentesis and what could happen then. And then you have to just make sure that whether she knows what is meant by Down syndrome. First of all, that should be your statement. You have to just say that what is meant by Down syndrome and why this test is being done for all the pregnant women, and what sort of an implication, if at all, if it is, if that's going to be a Down's baby, so what are all the implications that might have. Okay, a bit about that, not in detail. Okay, so this is just to say that she's at a high risk, that is 1 in 4 risk. So meaning to say, so believe me, after the diagnostic test, so most of them, around 75% of them, or 3 out of 4 will turn out to be normal. So all your efforts will make Valerie scared that, oh my God, I'm going to get a Down's baby. What my life is going to happen if I'm going to have. We delivered in a consultant-led unit. My God, the doctors are going to operate on me. I was dead scared. Not that. All right. So it's just going to say that the screening test has been done for you, and you have been found to have a bit of, you are on the higher risk side, and we are just going to work on the diagnostic options, whether to confirm that it is really going to be a Down syndrome or not. Okay. And at that point of time, we will be discussing you what are the further management options. Okay. So don't ever try to say that she wants to terminate or she wants to continue. Please do not, because you're overburdening the patient with too many information, right? So, for example, if she is going to, she's just come for a consultation to know about her combined testicles. So that is her idea when she came to you. But you took her to the labor care. She was really damn scared when you talk about that. All right. So that is not this one. Okay. So don't try to fill the gap with 10 minutes. Okay. You don't think that if you go on speaking on and on and on and on, you'll be given full marks. No. So as I told you, it is customized, tailor-made knowledge for that particular task and what the role player demands, and not like what and all you know about your Down syndrome, what and all you know about your first and second trimester screening, and what and all you know about everything, right? So that is what is expected out of you. You'll have to be smart, crisp, and answer to the point. Even if you finish in 8 minutes, even if you finish in 9 minutes, do not worry. Okay, so believe me, this task, if it is well done, if it is well prepared, she will finish it off in 7.5 to 8 minutes and nothing more than that. So in the event of that, you might invite some questions. So any questions from Mary or any questions from Mrs. Richard. So all that would be done for you. So unless or until you are very, very clear and specific and well prepared. So believe me, this is a repeated question for you, my dear. For in especially the post-COVID days, you're getting this question very often. So please focus on whatever this particular task demands and not whatever you know. So that is where you have to understand this, and that's why we taught you about customized, tailor-made knowledge for that particular task and for that particular role, as per the role play demand, right? So, my dear Tahira, you know the task, you picked up the task, you
Yes.
could able to communicate in a very soft-spoken way, in a clear, in an audible, and in simple, patient-friendly language. On the other hand, you did a bit of things which were not wanted for the station, and you burdened her and you scared her. She will have a nightmare. She will not sleep today because she'll be thinking all about the Down syndrome and all about the consented unit, because this particular woman, she wanted to have her delivery in a this thing. So imagine what if she's going to have a normal report. Yes, you have to talk about all this, whatever you spoke, when the task is going to have that she's a diagnostic test. Her FMU reports, her amniocentesis came out to be Down's positive. Then whatever you've spoken, the last 4 to 5 minutes would be absolutely fine, but not this particular task idea, right? Right. So let us come to
Yes.
whatever. Yeah. Great. So let us come to whatever the task is going to tell her. So I told you very clearly, this is my first pregnancy and this is a planned pregnancy. Then you ask, have you been pregnant ever before? So that means two things. One is you didn't do active listening. Second thing is you tend to overlook. You are overlooking of whatever she's put. So you are traveling in your agenda. So in your mind, your question, your template is coming. So you want to just jump from one question to another question to the third question to the fourth question, and in the meantime, you lost the flow of listening, active listening to her, right? So that is very important, my dear. So whenever you do a task, please do an active listening. Right. So um, she was very happy in telling you that she became pregnant for the first time. That was a natural conception, and she's very happy, and all that is fine. See, it is just a report, a combined test report, which is say so. You need not have to feel sorry. There's something concerns. You are right in saying that there are some concerns, but you need not have to apologize to her, or you do not have to say, "I'm sorry, there is some bad news." No, this is not that task, right? Suppose there's going to be some anencephaly, some severe malformations, some pregnancy losses. You can say, I'm sorry, I have some concerning news, and this is what the news says. But otherwise, you can just say there are some concerns in the report, and you can directly go on talking about that. And your template was good, but it was not specific. Like, so families, you could always ask any other members of the family who got Down syndrome. Because I'm a woman who do not know what is meant by Down syndrome, and I really do not. My midwife told that Down syndrome is some children have some born with some physical features, some facial features, and some a little bit of mental IQ. Only that I know. I do not know much in detail. So it's up to you to explain to me in a few words about what is Down syndrome. Isn't that, my dear? All right, and ask if
Yes.
any of the family members have this condition. And you are supposed to ask, what is my occupation? What is the age of my partner? Don't you think all this is important for this task? Rather than your running your generic templates. Yeah.
Yes.
So I appreciate you when you ask about cervical screening because she's 40. So that's absolutely fine. But otherwise, not routinely needed, except in early pregnancy and antenatal cases where they come with early pregnancy bleeding, where there's first trimester bleeding. Unless and until that is going to be a first trimester bleeding, it's not necessary for you to ask cervical smear, but here it's 40. That's I appreciate that you asked. And then when we come to the next thing, that is your management options. So you were asking the routine questions. That was fine. And you were asking about the support, you're asking about the smoking, the alcohol, and certain things. Like when I said I quit smoking, you said, good. You can take this in two things. One is that you appreciate the patient for whatever is done. Second thing, it might sometimes look judgmental, that is, you're judging me. So even if I'm a smoker, you don't have any business to judge me, right? Isn't that?
Yes,
So
yes.
yeah, so play safe. You want to pass this exam, so play safe. Be very strong in your communication. Use very apt words, and if you feel that you think that might offend the patient, please not say. So I've got a very specific way of counseling about smoking and alcohol, which I'll be telling you guys when you come for the courses or for our sessions. So in detail about a few words, but that will really, hit you exactly at the point, so that you'll be able to score very even if you miss something in your clinical knowledge, your communication with the patient is going to be very excellent, and this is going to be definitely passing station. All right. So you'll have to be really empathetic, really interactive, and really have do an all active listening. And I told you the formula. The you have to be safe, empathetic, as well as a knowledgeable middle grade doctor with a good set of communication skills. Right. And then then the rest of the things were like, yeah, so you can just offer us some support, some empathy, but not necessarily a breaking bad news. You explain to her what is a combined test. Yes, that was good. Say what is a high risk, what is a low risk. Yes, you offer her to be referred to the fetal medicine unit, and then where they'll be doing tissue sampling of the afterbirth, that is a CVS, or the amniocentesis, that is under ultrasound guidance. The local area will be numb. So all that was part was correct, and the accuracy of the test, and you were correct in telling about how soon the results are going to come or how they're not going to come. It's highly important that you do not miss an IPT, because especially nowadays it is being funded by the NHS, but not all the NHS trusts, but most of them. Okay. So, but you can still say it's a diagnostic test, but it is 99% accuracy, and it's going to be a non-invasive test, because they do not want a needle prick. Okay. Suppose if you ask me, if you don't tell me, if you don't ask me the choices, you might as well miss. Suppose if you ask me the choices, I don't want to get myself pricked, because you were telling some 1 in 200 dangerous risk of getting miscarriage and other things. So I don't want to do that, give that risk to my baby. So I would like to go as well for an IPT rather than a serious amnio. So you have to involve more in as a shared discussion and a shared management option. Okay. So as I told you, you'll have to give all the options to the role play, and she'll be the one to decide. And then always, yeah, the closing was again with the patient family, because you went on and on and on. You actually mingled the tasks. I would say you this is just a screening test, a combined test, and discussion of the combined test. But you went on, and somehow you couldn't finish the session. Believe me, my dear, whatever you're going to speak after the 10th minute, nothing is going to get scored. And if you don't speak about the patient information leaflet and support groups, that is going to lack. That's going to put you down just because that's specific marks. So as I told you, you'll be getting the maximum attention span of your examiners. The first 2 minutes and the last 30 seconds. The first 2 minutes, as I already told, the agenda fixing, the introduction, the confirmation of the purpose, and the agenda fixing, which is from 50 to 55 seconds. The second 1 minute is the history of presenting illness. So it this is a basic medical school teaching, as I told you, basic third year medical school teaching. We'll be teaching about the history of presenting illness. You have to speak in detail about that. That's going to differentiate you from the rest of the 13 candidates in the circuit. The last 30 seconds is how you're going to close the task. How you're going to close. So you have to give a patient information leaflet, support groups, have a follow-up appointment with a review of the results, have a consultation with a consultant. You'll be writing back to the fetal medicine, referring her to the fetal medicine unit, all right? And you just thank her for the time, all right? So this is going to be a task, and it may not be the way exactly that you did, my dear, all right? So any doubts on this, Tahira? Any doubts on this, please? Yeah. So any doubts for anyone else? Any doubts for anyone else?
No, ma'am.
Thank you, guys. So we'll go for the next task. So who wants to do the next task, please? Guys? Well, then I have to pick up. Dr. Manikam, are you ready? Dr. Manikam?
Yes, ma'am. I am ready, ma'am.
Great. Yes. Right. So let us have our next task, please. Oh, I don't know. Right. So let me share my screen. Right. Dr. Manikam, are you able to see my screen, please?
Yes, ma'am. Seen, ma'am.
Yeah. And are you able to see the clock, my dear?
The timing I am not able to see, ma'am.
Yeah. Let me focus. Excuse me for that. Right. Yeah. So guys, the moderator is always with you, in touch with you. So anything regarding the courses, anything regarding anything, as far as this MSUG part 3 is concerned, you can communicate with me, or if I'm not able to exactly know answer to your queries, you can contact with the moderator. So she'll be providing you with whatever is your need. Okay. So we have the moderator also with us in the group now. Right. So your 2 minutes. Shall I start your 2 minutes, Dr. Manikam?
Yes, ma'am. Yes, ma'am.
Great. Okay. So your 2 minutes starts now, my dear. Right.
Hello. I am Dr. Monikam, one of the doctors in the Urogynec clinic. May I confirm your name and age, please?
Hello, doctor. I'm Associate Officer. I'm 29.
How do you want to be called?
Yeah, please call me Susie.
Susie. your information says that you have come with the complaint of a swelling in the down below and painful. Am I right?
Yeah, you're right, doctor.
May I know what are the any other concern you want to discuss today?
No, doctor, I just want to know what's happening, and I just want to have some good treatment for this.
Before discussing your management options, shall I ask you a few questions to know more about you?
Sure, doctor.
And please tell me, Susie, about this condition.
Yeah, doctor. It is for the past a little more than a year. I'm having this sort of something from my down below. Yeah.
Is it any other? That's all. Is there any discharge from it?
Not really a discharge.
Can you tell me more about this?
Well, yes, doctor. I'm just having this sort of something coming from down below, and as I told you, it's a little more than a year, and it's paining, doctor. And I feel some problems with my waterworks also. I feel that I do have to, sort of some drops are coming out even after a completely weeing out also. And it really affects my my intimate life with my partner as well. Yeah.
Is it painful when having intercourse? Sorry,
Yes, doctor.
I have to sign post. Shall I ask you like this? It is somewhat intrusive. Okay.
Yes, doctor.
Do you have any bleeding during intercourse?
No, I don't.
Do you leak when having intercourse?
No, doctor.
Have you ever been treated for any sexually shared infection?
No.
This is for the past 1 year you are having this complaint. When you pass urine, do you dribble afterwards?
Yeah, that's what I told you, doctor.
Still you are feeling that it is the water bag is not completely empty. Is it so?
Yeah, yeah.
Do you have any pain in your tummy, lower tummy?
Some sort of, yeah. It was like pain down below, doctor.
Okay. It's always there. Pain is always there.
Yeah, yes, doctor.
The passing urine does not relieve the pain.
No.
And pain during intercourse, again, I'm asking, it is an intrusive question. Is it at the beginning of the thing, or when he's deep inside it, the pain is more?
Actually, it is like when it is because of the penetration, the pain is more.
Okay. Do you have any fever?
No, I don't have fever.
Do you go to the toilet frequently?
Not really.
Do you rush to the toilet?
No.
Do you have any problem with your bowel works?
No.
Please tell me about your periods.
Yeah, my periods are regular, doctor. My last menstrual period was 10 days before.
Do you have used any contraception?
No, doctor. My partner sometimes actually uses condoms.
Are you up to date with your cervical screening program?
Yeah.
Have you ever been pregnant before?
Yeah, doctor. I've got 3 kids and all were normal deliveries.
Any problem with the deliveries?
No. Except that the last one was the labor was a little prolonged, and then yeah, the doctor had to just put some these 2 large metallic spoons, and there was a small cut given down below and some stitches replaced.
Is there any discharge coming out from this swelling, foul smelling like that, or any pus like discharge coming out?
No pus as such, doctor.
And what have you, any treatment you have done for this?
Doctor, actually, I was checked by my GP and she told some bugs in the urine. She gave me some antibiotics. That was around 3 to 4 months before. A couple of times I've taken antibiotics, but still, things didn't seem to improve.
Are your partner fit and fine?
Yeah, of course.
Do you have any medical condition for which you're treated by a GP?
No.
Are you on any medications?
Not at all.
Any allergies?
No.
Any surgery in the past?
No, doctor.
Any family history of concern?
No.
Do you smoke?
No, doctor. I don't smoke.
Any alcohol?
That was occasionally in parties.
Any recreational drugs?
Not at all.
Weight to height ratio, no?
Yeah, that is around 30.
Do you feel down depressed for the past 4 weeks?
I'm not depressed, doctor, but I just need some solution for this, doctor.
You're anxious about this condition. I'm sorry
Not,
to hear.
not really, doctor. Not really, doctor. But this has been a little more than a year, and I'm planning to have one more baby. So I just want to settle with this and then plan the pregnancy.
Really sorry for this condition, but treatment is available. Do not worry. Do you know your blood group?
A positive.
Do you have any reservation against transfusion?
Not at all.
Do you want to add anything?
No.
So I want to examine you in presence of chaplain with your consent.
Yeah, doctor, that's okay.
Ma'am, any other slide, ma'am? Nothing, ma'am? Only
nothing. Nothing.
Okay,
yeah.
okay, okay, ma'am. And from the examination, it looks like, I want to examine the down below, and it looks more like condition called outpouching of the urine tube, having some collection of fluid inside. This is a result of some bugs infecting some tissue inside around the urine tube, and this needs to be treated by this we call as urethral diverticulum. Have you ever heard of this?
No, doctor.
So your care will be under the care of the group of specialists, including my consultant, specialist nurse, the physician, the pain doctor, and the microbiologist, and the imaging doctor, the doctors treating the condition of the urine pipe and the bladder, that is the urologist and urogynecologist, and the continent nurse, and the psychological counselors, and the support groups are also available. So after doing some blood tests for you, and after getting your consent and explaining the risks and benefits, you'll be done a camera test. Shall I continue?
Okay.
A camera test will be done to see whether there is a outpouching, and they'll put some dye inside, coloring matter, that is a dye inside the water bag, and that will be an X-ray will be taken that will show the presence of this outpouching, that is the diverticulum, and they may do, after getting your and explaining the results to you, and after getting your consent, they will do a surgery, that is an operation. This can be managed with the operation called the roof of the cavity will be kept open by a opening and stitching. After putting you under sleep, this is called marsupialization. This can be done. If possible, the specialist that is treating the urine pipe conditions, they will try to remove the whole thing. There is a risk of infection can occur, and sometimes bleeding can be there. Sometimes the leak may be sometimes present. This can occur, but they are well trained and they'll do this. And
so you don't give me any medicines, doctor?
If there are any infection, before, as you have been treated by urine culture now, they will repeat the urine culture and see for any infection. If it is present, they will do that. They will take the fluid from the pouch. After ruling out the infection only, they will do the camera test and all. Then after excising that, after removing that diverticulum or the pouch, then you will be treated with antibiotics, painkillers, and they will be followed up with the repeated, follow-up and examination of the part, and they'll be giving you some local emollient creams and antibiotic gel also. They'll be providing you. Do not worry. This is a treatable condition. I'll give you the patient information leaflet, and I'll write back to your GP, and I'll arrange an appointment with the consultant so that you can come and have a discussion. Anything else you want to know?
No, it's okay, doctor.
Thank you, Susie, for your time.
Thank you, doctor.
I have exceeded the time, ma'am. Sorry, ma'am.
Good attempt, Dr. Manikam. So,
Thank you, ma'am.
what do you think went on well, and what do you think you have missed?
Ma'am, I should have explained about the differential diagnosis, ma'am.
Exactly.
So any cyst arising, this Gardner's cyst like that, anything arising from the anterior wall of the vagina, or any other inclusion cyst, that also I have to explain, ma'am. And cystocele is also a differential diagnosis, ma'am.
Yeah. Yep. So yeah, you were certain things you were correct that you spoke about. That certain things need to be improved on, right?
Yes,
so I never say anything is difficult. It's always the challenges. So there's always a scope for improvement. There's always a scope to learn. So each day is a learning lesson for all of us in one aspect of that, in our careers, in our jobs, in our lives. So we all do vicarious learning in so many ways, right? So it was a good attempt. You could pick up the station, but somewhere in between you are just fumbling whether is this cystocele or is this going to be urethral diverticulum. Thankfully, you somehow you could get finally that it was an anti-vaginal diverticulum. But Dr. Manikam, there were much of jargons, my dear. So you have to really work on so many things. So diverticulum, I was feeling as Susie Robson, I was finding it difficult myself to understand that. And then you were telling about removing the roof and this and that. And then, yeah, of course, you didn't tell about what are the other options. And you never bothered about my concern. I said, I want to become pregnant. Yes, yeah, that was my concern. So that's why I said, doctor, I'm planning to have one more. So you should be able to come to a conclusion. And as I told you, you have to always start with the basic option. So I'm sorry to say that we cannot, since you do, really symptomatic, we just cannot, wait for the nature to act. That's an expectant one, which is, of course, not suitable. We don't do to that, even if it's not a dreadful condition for her to do an emergency surgery or something, but still the surgical option is the only one. Yes, you are correct in telling that she'll be given if at all she gets any bugs in the urine, she'll be given antibiotics, but per se, urethral diverticulum per se, for the urethral diverticulum per se, you do not have anything to add on as a medical treatment, right? So you have just have medical option. You have just have surgical options to speak, right? So let us come back to whatever we are supposed to read. So yes. So first of all, introduction. Contribution of purpose and agenda fixing, explore concerns and expectations. I know, my dears, Eurogaining stations are long, challenging stations as far as the information gathering is concerned. You have to go on and on and on and ask about so many things. Eurogaining stations and maternal medicine stations are challenging in terms of time, because students generally struggle to finish within the time the information gathering, because you have to speak so many things, ask so many things. Right. So please ask about the onset, the duration, the discharge, and pressing. Of course, that you ask. Any test, any treatment she has taken so far, you ask about treatment. Ask whether the swelling gets worse at the end of the day, or whether she's comfortable after test to rule out whether she has got any prolapse or recurrent prolapse, which is again an important differential diagnosis. Ask about frequency, ask about urgency, ask about leak, ask about avoiding dysfunctions, ask about any post-maturation symptoms, especially dribbling that she actually let out, but I'm not sure whether you could make out what she spoke. Then you ask about whether dribbling. I told her in the beginning that I'm passing, even after I completely wee, I tend to spill out some droplets. So that is what the patient will say. She will not say it's dribbling. She may not say. she may not say. Sometimes they are well educated, well aware. They might say dribbling, sometimes they may not. So these are certain common languages that you have to be aware of, or you have to either ask her. Okay, so do you spill out some droplets even after you completely wee, or do you feel that you're completely emptied? Such things would be a better questioning, way of information gathering. Ask her about any burning, any blood in the urine, any painful sex that she herself came up. In case she doesn't ask, you have to ask her. Ask her about her bowel habits. Ask her about the quality of life. But actually here, I try to help you out by giving you all the necessary information. I told her that getting intimate with my partner is affecting my quality of life and all that stuff. So that itself is a clue to you, so that you will be able to pick up. So please, my friends, please pay attention to whatever role player speaks. She gets you some cues. There'll be something that she's able to guide you through. Okay, you have to be attentive enough and smart enough to grasp that. Okay, so that is going to give you a passing station instead of beating about the bush, instead of talking about traveling in your own agenda. Right, you keep on asking questions from one after to another, to the third, to the fourth, and finally you don't address her concerns. Okay, so please travel with the role player's agenda. She's going to befriend your role player. She will give you success. Okay, don't keep on asking unwanted questions at the same time. Never miss important questions. So organic history, the menstrual history, the smears, the contraception. Yes, you ask about a difficult childbirth. You ask about childbirth, and she came up with some difficulty during the last childbirth. You asked about her medications, past allergies, and all that. Please ask specific questions. As I told you, it's customized, tailor-made. Please ask about any operations that she has done for any, past surgeries, any leaking. You do not have to ask about SUI. She may not know SUI, you and I know. So you can ask her, have you ever been treated for any, have you been undergone any surgeries for any leaking, urine leakage or something? You can ask questions like that. Or was she given any injections for the same? Okay. So this again could be a reason for her dribbling. Any specific family stuff concerns, smoking, alcohol, drugs. So please signpost before asking drugs, and always ask about occupation. Okay, she might be lifting some heavy weight. She might work as a janitor. She might be a weightlifter by profession. We never know. So please ask her occupation. If you don't ask, that might pull your communication. Sorry, that might pull your information is gathering. So my friends, so please ask specific questions for the patient that will give you, so that you'll be able to extract all the necessary information from her within the stipulated time. Unless and until it's going to be specific to the station and not the generic template, you will not be, having a smooth sail for passing this task. Okay, so please ask her occupation, ask her support at home, ask what sort of fluids. Okay. All right. What sort of what is a fluid? So never ever miss the fluids that she's taking about in urogenic stations. Okay, it's mandatory that you ask about any domestic violence and the support at home and the BMI. Differential diagnosis could be diverticulum, could be a cystocele, could be vaginal Gartner cyst. Okay, could be anything. Could be some. It could be. These are the few common things. It could be a pelvic problem. It could be urethral, it could be anything. Okay, so just have all these differential diagnoses. As I told you in the beginning, a safe doctor is the one who has got the differential diagnosis in her mind before she approaches. So even if she is able to pick up the station, you are a safe doctor, then you're able to ask questions well in the information gathering, well in the step presenting illness, having this differential diagnosis in the mind. If you don't approach that way, if you're going to talk only about urethral diverticulum, I'm sorry, you'll not be able to clear certain domains, right? So please ask specific questions. Please have a broader outlook, have a helicopteric approach, a view over this task, so that you'll be able to speak in terms of differential diagnosis, and that is how you can impress your examiner in the second minute that I was telling you about the history of presenting illness, right? So a safe doctor is the one who's going to, right from the beginning, is going to approach this task having the differential diagnosis and not getting stuck to one particular diagnosis. So that is what is called as a, that is who we describe as a safe doctor. So my dear friends, you will be speaking, having the differential diagnosis in your brains before you start taking the history. So inflammations, you do dysuria, that's painful and burning urination. Dribbling is urinary leakage after urinating. These are the common words that we speak. That is the jargons we will be avoiding. And dyspnea, that's the painful intimate life or this painful intercourse. So it is nothing but your diverticulum is a condition which is a pocket or outpouching, which forms next to the urethra because it is most often it's connected to the urethra. This outpouching gets repeatedly filled with the urine during the act of urination and thus causing the symptoms. So wait and watch is not possible for her. There's no tablets to treat her. So the only option is left is for her the surgical option. That is again with the consultant. It's a group of specialist doctors, including my consultant, the urologist, the specialist nurse, the counselor, because these women will be distressed because of the pain, because of the dyspareunia. So because of the dribbling, they'll be distressed. So you can offer them counselor services. So surgical option include just cutting into the sac neck or creating some permanent opening or removing the sac completely. The benefits are that the symptoms might get relieved. The risk is that she might develop some recurrent bugs in the urine, what we call as urinary tract infection. She might develop some leakage and coughing or laughing. There might be an increased risk of relapse. The condition can recur. So this is again one of the risk factors. There might be some unnatural opening, which might tend to occur. So that's called as fistula. But unfortunately, if this condition is not treated, again, she might have repeated bugs in the urine. She might develop some stones. She might be getting leaks, and very rarely there's some sinister changes can do occur. So this is again a patient safety point. So if you don't tell that might pull down your patient safety. So close with the action plan. That's your patient information leaflet and support group. So this is a very simple task. This is going to really help you out in so many things. But unless and until you are prepared for this, you may not be able to clear this task. All right. So any doubts with this, Dr. Manikam?
No, ma'am. Thank you, ma'am.
Yeah, thank you, Dr. Manikam. So any doubts, guys? Any other doubts, guys? Any doubts on this task, my dears? Are we going to move the next task, please? So we have 2 more tasks to go. I would like to have Dr. Prasanna with us for a task. Will that be okay?
Yes, ma'am.
Okay, my dear. So yeah, I will be focusing a task to you. Right?
Yes, ma'am.
All right. So let us take something which is right. So this task, my dear, is going to involve a lay examiner. All right. This is task number 3. So let me focus your timer. And timer is here. Right. Right. So are you seeing the timer, my dear? Are you seeing the task?
No, ma'am. Task is not visible, ma'am.
Task is not visible?
Yeah.
Right. Okay.
Ma'am, the task 3 slide is visible, ma'am. That content is not appearing.
Yeah, content is coming now, my dear. Right. So we'll be going with the third task. The task is here, and we'll be starting the 2 minutes for you. Yeah, your 2 minutes starts now, my dear.
Yes, ma'am. Any other slide, ma'am?
No, my dear, there's only one slide, and whatever you want to type, you can type in the chat box, and you can send to me, or you can send to the everyone. I mean, to everyone, or you can send to me.
Yes, ma'am.
Right, the 10 minutes starts now, my dear.
Yes, ma'am. Hi, I'm Dr. Presna, one of the doctor in the early pregnancy unit.
Hi,
How may
doctor. Hi, doctor.
how may I address you?
Yeah, please call me Tina.
Okay. What's your age?
Yeah, I'm 15 years.
Okay. China. You are 9 weeks of pregnancy. You are here to discuss about your the termination of sin. Am I right?
Yeah, that's true.
Okay. Tina. Yeah. This is first time I'm meeting you. I need to ask you a few questions to know about you. Then we can make a mutually agreeable plan. Is that fine for you?
Yeah, that sounds great. Yeah.
Tina, I'll assure you whatever we are discussing, I'll keep confidential. Without your consent, I won't disclose to anyone.
Okay, doctor.
Can I continue?
Sure, doctor.
Yeah. Tina, can you tell me more about this pregnancy?
Well, doctor, the other day I just got along with my boyfriend, and this guy, he forgot to use the condoms, I believe. And I never knew that I became pregnant, but it was just casually, I had to go for a testing, a medical testing, where I was told that I was pregnant, and by making a urine test, doctor. But, I'm just in the school and I cannot take this pregnancy, doctor. I just came for discussing my options of termination.
Okay, Tina. I can understand. Definitely, there is help is available. Tina, this is the consensual sex.
Yeah, doctor, this is my boyfriend.
Yeah. Okay, fine. How about your cycles?
Yeah, my cycles are regular, doctor, once in 30 days. And my last cycle was, I believe, little more than 2 months.
Okay, fine. Have you taken any blood checks and scan so far?
No.
Okay. Do you have you used any contraceptions before this pregnancy?
No, doctor. Actually, I'm planning to start one, but this is the third time that I just got along with this guy.
Okay, fine. Have you any planning for any long-term contraception also in future?
Uh, yeah, I think now I'll have to really seriously think on this because I just cannot take over this unplanned pregnancies.
Okay, fine. Tina, some of my questions are a bit embarrassing and personal, but it's very important for the management. Can I continue?
Yeah, sure, doctor.
Have you ever treated for any sexually shared infection?
No,
Um, how the any sorry, do you have any multiple partners?
no, doctor.
Okay, and your parents know about this?
My parents know that I have a boyfriend, but they don't know that I'm pregnant.
Okay, Tina, would you like to inform your parents?
I have to think about this, doctor.
Okay, Tina. Uh, uh, how, Okay. Do you otherwise fit and healthy?
Uh, well, doctor, I'm okay. I'm fine.
Are you allergic to any medication?
No,
Underwent any surgery in your tummy or down below?
no, no.
Okay. And do you smoke?
No, doctor, I don't smoke.
Do you drink?
That's in parties when I get along with friends.
Okay. Occasionally.
Yeah,
Okay. And are you on any recreational drug?
no.
Okay. Have you aware about your weight to height ratio?
Uh, I don't know, doctor.
Okay. How is support at home?
Yeah, my parents are supportive.
Okay. What do you what are you doing?
Doctor, I'm in the school. I'm in grade 10.
Fine, Tina. Okay, Tina, have you I mean, are you felt any depressed or down in last few weeks?
No, doctor, except that, I'm thinking pretty sure that I will not be able to carry on this pregnancy.
Okay, okay, Tina. Tina, thank you for sharing all the information. Do you want to add anything?
No, doctor.
Okay. Tina, with your permission, I would like to examine you in presence of chaperone. Is that fine for you?
I don't think I need an examination, doctor. Just tell me about my options of termination.
Yeah, okay, okay, Tina, as your wish. Tina, there is two options available for you, and one is the before that, I need to do the some of the test for you. That is scan to find out the how many weeks of your pregnancy. Okay, and
Okay.
according to that, we can plan the termination mode actually. And you said your cycles are regular. Most probably, you will be at 9 weeks of pregnancy.
Mhm.
And we have um, two methods. One is the medical methods, and another one is the surgical methods. And mostly, this medical method, what we will do is we'll just give one medicines. After that, after 48 hours from the first medicine, we will give another 4 tablets.
All right.
And following these tablets, what happens? Some of them will have the severe pain, like a labor pain. So,
Mm-hmm.
and you need during that time you need definitely support, Tina,
Okay.
because when you have somebody you known to you, if somebody is around you, you feel better actually because it's like
All
a
right.
typical labor pain. So we always would like to encourage you to inform your parents or your audience usually.
All right.
Okay. And following these medications, you will get bleeding and pain. Mostly, this bleeding will last for few days to weeks. After
Mhm.
2 weeks of this medication intake, we will again check the scan to find out any pregnancy tissues remaining. Usually, this method out of 100 women, 98 women will benefited with this method, and only out of 100 women, 2 women will undergo the surgical method too. Sometimes, if the pregnancy is not completely clear, you might require surgical technique to remove the pregnancy tissue.
Uh-huh. Okay.
Are you following, Tina?
Yeah, doctor. Okay.
Okay. If another method will be if the medical method is failed, or if you have severe bleeding after taking this medication, or if you have any fainting attack with because of excessive bleeding, you
Mm-hmm.
might require surgical method. Okay. In that, we will after optimizing your health and after the this anesthesia doctor's review, we will take you this pregnancy tissue under anesthesia. In that, what we'll do after we will giving some injections to I mean either the general anesthesia, that is just will put you into sleep, and then we will do some according to the pregnancy size, we will use some specific cannula to dilate the neck of the womb. Then we will take out the pregnancy tissue.
All right.
For this method, you have some side effect like anesthesia related side effect, and as like any technique, sometimes you may have heavy bleeding, and
Mm-hmm.
few of them develop infection following this. Even with the good aseptic sepsis, also some of them might develop infection also.
Okay.
These are all the options available for you, Tina. Do you have other concerns?
I have to think about this, doctor, and as well as I have to just, discuss with my boyfriend. Mm, well, doctor. So, can I come back after a couple of weeks?
Yeah, Tina, but don't prolong much time because you already reached 9 weeks of your pregnancy. So we need to go with if you wish medical method, then within 10 weeks we need to go with this medical method. Okay.
Okay, doctor. Yeah, that's okay.
I'll give the information leaflet because I given lot of information for you. If you have any doubt, you can ask me. I will involve my consultant also. For this next appointment, and I'll document whatever we discussed. Okay, I'll give you a copy to you.
Okay. Yeah, that's okay, doctor.
Yeah. Thank you, Tina.
Thank you,
You think
doctor.
informing your parents?
Yeah,
You need
please continue, my dear. Yeah.
yeah, and you need support during this procedure, so we would like to encourage you to inform your parents also.
Let me think over this, doctor.
Thank you, Tina. Thank you.
Thank you, doctor. Thank you, my dear. It's a good attempt. A very well made attempt. You are as pleasing and as sweet as you talk all the time, especially with Tina Williams. You're all the more sweet. However, a few things have to be worked upon. So she's a teenager. She's coming to you, and you were you introduced yourself and you asked her by what name she has to be called. So that was a fine thing. And then um, you built confidence in her. You keep up the confidentiality. You told her that whatever you're going to discuss will be confidential, and you will not be able to tell anyone. You will not be telling anyone. So that was a fantastic point. So she felt comfortable and communicative with you. That's fine, absolutely fine. As well as if you could also add that some of your questions will be personally inclusive, but that is needed. All these details are needed for the management options. So she could have felt all the more, a little more, open up with whatever she wants to tell. Okay. So whenever we see some teenagers, it's always better that if we can just, ask some few words about just a means of building rapport, because they are generally, tough to handle. Sometimes they might behave arrogantly. They may be angry, or they may not be able to open up whatever they are supposed to. So whenever we deal with a teenager, we can just ask her, "How are you doing today?" And I think you're in the school, so how's the school going? So just rule out bullying and undermining in the school, right? And then you can ask her, "Could you tell me how you became pregnant?" So instead of directly asking her what is the confidential second, you just ask her, "You get me details about how you became pregnant." Then she'll open up. And she's a 15-year-old, and then she has got a boyfriend. So please ask her boyfriend's age. If that's going to be more than 4 years, then you have to involve the child safeguarding team to make sure, even if it's a consensual sex, even if the boyfriend, if it's going to be more than 4 years, that means you have to involve that to make sure that she's safe in her relationship. She's not under threat. She's not under nobody's doing her favor in offer of sex. Such things. Nobody's offering her any gifts or something. Nobody's intimidating her. All this has to be ruled out because that forms your patient safety. Well, so let us come back to the answers. So you can just ask about after introduction and your confirmation of purpose and agenda. Ask her how are you going today. see that you're alone, so you're assured confidentiality. So just ask her views about, about this particular incident that happened to her. How she became pregnant and other things, and you ask her whether she is on any contraception, and she has come here for an unplanned contraception. So please, then and there you can do the contraception counseling. So when she told about condoms, yeah, condoms are good in preventing sexually shared infections, however, not so in pregnancy. So if you'd like, Christina, at the end of this consultation, I can put you in touch with a contraception doctor. At the end of this pregnancy, I can put you in touch with a contraception doctor who's going to give you some reliable contraception to help you in preventing future pregnancies. Of course, you asked that, but still, it could be as a flow. It should be coming as a flow instead of asking, questions which may not be able to bring out the exact words that is there in the script. Okay, so you can ask them specific, clear questions like instead of saying that what are our ideas about contraception or something, you can just say that it's good that better that if you can just get along with some suitable reliable contraception, as well as, so whatever may be the use of whatever may be your permanent contraception, you could as well do practice with condoms, which will help preventing sexually shared infections. So that's going to be a patient safety points. You were correctly telling her whether her parents were informed. She just told that her parents know about the relationship, not about pregnancy. So, and even at the end, you closed by saying that you please involve your parents because you will be needing support. So that's an excellent point. And yes, the present pregnancy details about how she became pregnant, consensual, whether the abuse, rape, and all this. Of course, the partner details like age, and if the partner is more than 4 years, be following the safeguarding midwife to ensure her safety. How many issues, how many weeks, any issues, what are views on pregnancy. Whether this girl is coming to you just because she's being threatened by the partner or her friends or family members that she has to go for an abortion. So first of all, ask what are her, because here, of course, she herself volunteered that in the beginning that she's too small to have a pregnancy, but still, it's your duty as a safe doctor to rule out whether she is under some threat or pressure to do this pregnancy, to terminate this pregnancy. Ask her past pregnancy details, if at all, if it is there. Ask again, history is LNP, yeah, that's good. And ask her HPV vaccination in the event of she is not getting vaccinated, you can advise her to go for vaccination. Yes, whenever you ask for sexual history, please do signpost. Yes, of course, you are already done in the beginning, but generally the other stations we'll have to signpost and ask some of my questions. It's not personally inclusive, but it's needed for but all this information is needed for our management plan. So just ask her, are you stable in your relationships? Just these two questions is going to bring out all the necessary information that you need. Just ask her that question number one, are you stable in your relationship? She's going to say yes or no. In the event of she's saying no, just ask her, have you or your partner been ever treated for any sexually shared infections in the past? So these two questions is going to bring you all the necessary information. Suppose if that question, the answer to the question is, are you stable in your relationship with Dana? Then you can say that if she says no, say, could you tell me more details about your relationships? Then she say, okay, I had a relationship with my boyfriend, this is my second boyfriend, this is my second partner, whatever is there in the script, she's going to tell out to you. And then you can ask the third question as, have you or your partners been ever treated for sexually shared infections in the past? If at all, if she says yes, ask her to tell about the details and ask her permission to review the notes. All right. And yeah, then comes, of course, the contraception you asked about them, and of course, the conflict with the contraception has to be given as well. The character history, the medical history, the past history, any allergies. Please ask about blood grouping and typing because you'll be taking suppose you have a surgical option to be discussed, so please do blood grouping and typing. ask a blood grouping, and invariably these guys, these teenagers, they will not know. So then she'll say no. So in that case, say, okay, do not worry. So I will just advise. We'll be ordering for a test to check for blood group and typing. So that will come your investigations. And then ask her any reservation for transfusion, even if she doesn't know about the group. Just ask her whether she's a Jehovah's or she belongs to that family, because some children do have that, do have been brought up that way. Surgical history, yes, excellent. Family history, again, it's just a routine question. Smoking, alcohol, drugs, again, it's a routine question. Of course, the school details, support at home, mental health, and yeah, try to summarize if possible. So summarizing things will make you that you will make your examiner feel that you are a safe doctor, so that you don't want to miss any details. You're summarizing whatever she told, and you're inviting questions to say when you're offering her whether she needs to tell us any other information, as well as you're made an active listening. Then comes the applied knowledge part. So, my dear, you're speaking to a 15-year-old girl, so concerned, confidentiality, and application of her guidelines, not to phrase the guidelines as per se, but the feelings. So I can see that you're able to understand what I'm saying, you're able to choose the options that I'm saying, and you're able to communicate back to me what is your option. So that should be the one. So we need to say she has to be competitive to understand whatever we are saying and communicate to you what is her option, right? And then say that pregnancy is abortion is a safe option. Complications do occur. So again, we have the medical methods. You'll be telling the risks of the management, which you correctly told. And you said you needed some support because you'll be bleeding. Someone is to be there with you to take care. So that was an excellent point. In fact, that's why you recommended her to involve the parents. Surgical procedures, yes, you have the manual explanation and the surgical option. So each and every procedure has to be dealt a few words about the procedures, including the risks and the benefits and the procedures per se. Yes, you involve the anesthetist, so that is a good point from your side. So other option, you can always tell a safe doctor is the one who's having, you know, a lateral approach, rather in the sense like lateral way of thinking, including all a broad spectrum of thinking, including the options. In not only the city, even in the clinical knowledge, some women some girl in your condition would like to continue the pregnancy and raise the baby or give the baby to adoption. So that can be, so it will not be offensive if you speak this way, because that will make you a safe doctor. You are traveling with the role-based agenda, but you have something more to add, because that could be an eye-opener for her. She wouldn't have been discussed all this by her midwife or her GP. So she has come to you, and you take this opportunity to give her other options, whether to continue the pregnancy and raise the baby or give the baby your option. And whatever her choice, you are here to help and support you as a group. And of course, suitable contraception at the rate of pregnancy, safe sex practices. Please inform the consultant and give a patient information leaflet and support groups. And she'll be having a follow-up appointment in the next week. But she will not be delaying it too long, like as she wanted a couple of weeks or something, because already she's 9 weeks. She might, if she delays more, so that might make things complicated. Okay. So the important points in this is confidentiality, involvement of the parents. You can recommend involving, but you cannot persuade her, or you cannot be strict with her and saying that she has to inform her parents. So that's not our job. And you have to establish a rapport with the school girl, asking about how is the school going, how are friends and peers, how are her, how is her school, whether she's being bullied or undermined, what about her partner, what's her age, whether this is a consensual sex, so whether someone is abusing her or she's under threat. So such things has to be told. And then of course the mental capacity assessment has to be told to the examiner, that you had this point also in mind when you're communicating with the teenager. And then of course you advised her for the follow-up. When you correctly traveled in the agenda of telling about the medical option, the surgical option, the pros and cons, and of course the suitable contraception also you spoke. And just of course you can involve the consultant, and this girl, she told that she didn't know her blood group, so you can just say, so just before the surgery, we'll be running a test to find out what sort of blood group you belong to, and check your blood count as well. It's a simple basic test that you'll be doing, and a basic ultrasound also can also be done for this woman before she gets into the theater. If she shows a surgical option, right? So this could be the closure of the station. So any doubts on this, my dear?
Ma'am, she told already she's with his boyfriend. Even that also we need to ask whether it has happened because of any thread or under the alcohol or drug use like that, ma'am.
Not really. It's a boyfriend, but still the boyfriend can abuse her. Still the boyfriend can threaten her. So because she's a teenager, so we have to rule out because this involves a lot of safeguarding issues. Or he might even gift her some costly gifts, some jewelry, some chocolate, something we don't know. She might get abused. So we have to make sure that she's safe in a relationship, irrespective of the partner's age. In the event of her partner's age is going to be more than 4, again, whatever may be her level of relationship or understanding or her intimacy with her boyfriend, still the safeguarding midwife will come and talk to her just to make sure that she's safe in a relationship. All right. Okay. Any other doubts, my dear?
No, thank you, ma'am.
Thank you, my dear. So, any other doubts, my dear friends? All right. So we'll be going for the last task of the day. So I need Bismil. Bismil is here. Bismil Syed is here.
Yes, doctor, I'm here.
Yeah, good. So we have the task for the last task of the day. Yep. Well, just a moment. Let me put this slide for you. My dear Bismil, are you ready for a metal medicine task?
No,
Hmm.
because I still have not reached to the module of maternal medicine.
Right. Okay, no worries. You want anything in the gynae?
Actually, yes, I have been covering sexual reproductive infertility, urogyne, and postpartum and all these modules because these are simple, so I want to cover them all.
Okay. So I will give you a task in labor and delivery. Will that be okay for you?
Yeah, that's fine.
Great. So let us start with labor and delivery module. This is again one of the time-tested recalls.
Doctor, sorry,
Yes,
Dr.
please.
Gunnar,
Yeah.
actually,
Huh.
I would like to do a sexual assault teaching station because I am very puzzled in that.
Well, sexual assault teaching task, right?
Yeah, because
Right.
I really needed to perform before any mentor. If you arrange, otherwise it's okay.
No worries, no worries. I can get you a task on sexual assault teaching that has been coming in the recent exams.
Yes, exactly.
And
It's coming and it's coming with the diagram that one is asking for what is it or all that.
So yeah, it's not every time that it came with a diagram. One time it didn't come with a diagram as well. All right.
Yeah.
So
Yes.
yeah, we can arrange for that. So don't worry. We will be doing a few tasks. Out of that, I'll get you a sexual assault teaching task for you.
Okay.
All right. All right. So let us go for the sexual assault teaching. Just a moment. Let me focus my slides. Right. All right. So right. So please start your. Are you seeing my timer, my dear? This one?
No,
Okay. Yes, just taking the task. Okay. Can you see the timer? Can you see the task here?
I can see the task.
The timer?
Yes, now I can see the time.
Yeah. All right. So you're just only one slide, and you will be given 2 minutes now to read the slide, my dear. So whatever you want to type in the 2 minutes, you can type in the chat box. Right. So your 2 minutes starts now, my dear.
So can I start?
Start, please.
Hello. Okay. Hello, I am Bismil, ST5, and you are?
Hi, I'm Wilma Thomas. I'm ST2.
Okay. Hello, Wilma. How are you?
Yeah, I'm good. Ismail, how are you?
I'm also good. So, how's everyone in the department with you, Wilma?
Yeah, everyone is fine. All my friends and my colleagues and the seniors are very helpful and supportive.
Okay, that's really good. So, at any time, if you need any help, we all are here to support and help you, Wilma. Is that okay?
Yeah, that sounds great.
Okay, so Wilma, what I understand is that you wanted to know about the management of sexual assault. Is that?
Yeah.
Okay, so Wilma, yes, we will go with that. But may I know that why have you chosen this topic?
Well, last week there was a patient. I was doing night duty with my senior, the ST7, and this particular woman came in a very distressful situation. This well, she came in the middle of the night where she was raped by 4 people, and but my ST7 was very efficient and trained in taking all the necessary information from her, and then he started doing the management plan for her. So this made me, read about this topic, and the next day I contacted my education supervisor, and then she advised me to see that Miss will be able to help you, and that's how I began. But you know something, I'm feeling so distressed and upset. I couldn't sleep the next 2 days because of this.
Oh, I'm so sorry to hear about that, Vilma. We are all here to support and help you. And surely this is a very distressing situation. If you want off from your work, then we are here to support you. Okay.
Okay.
So I can see that you are very enthusiastic to know about the topic. But is there any particular thing that you want to know?
Uh, Nothing. That I just want to know about how I should be able to deal a sexual assault case if I'm alone.
Okay, yeah, sure. So we will go through it, and I will tell you to how to approach the patient like that. And in the end, I will also give you some strategy notes, so the end videos, so that you can go through it at any time. If you feel any question in your mind, then you are feel free to ask me. Would that be okay?
Yeah, that sounds great. Yeah.
Okay, so now Vilma, coming on to the topic, when the patients like that when approaches to us, then there are particularly two aspects of the view. One is the forensic aspect, and other is the medical aspect.
Uh-huh.
But so we first of all we should approach this patient in a very empathic, and in a very sensitive way, because these patients can suffer from a long-term problem that is called as a post-traumatic sexual post-traumatic syndrome, and they can suffer from mental health issues. Their safety is at a risk, so we should offer them support and help. And most of the time it is seen the safety of these patients are at risk, so uh, we should also assess that. So first of all, we should take a thorough history of this patient. Like as you said, this patient was assaulted by multiple partners, so we will ask her that, like, where did it happen, and when did it happen, how much time has been passed since the sexual assault, and how many assailant were there, and after that whether she has drink any water or she has eaten anything. Are you with me, Vilma?
Yeah.
So could you please repeat that what we will ask from her?
Uh, Ask about the details of the incident and whether she ate or drank after the incident.
Yes, you are very, very good. And Vilma, I can see that you are a very good learner. Yes. So as you see, you have seen this patient, right? So did you ask all these things, or your ST7 managed it?
No. I was just observing what my senior was doing, and he's the one to ask it.
Okay, all right. So apart from this, after checking this, we should also ask, like, whether she was giving any drugs like alcohol or anything, whether she was under influence of any drugs, or whether her safety is at risk, whether she's been threatened by the weapons or any other weapons was used at that time. And apart from this, we will inquire about her, because as a medical person we have to offer her a pregnancy protection. So we needed to ask about her menstrual periods, her LMP, whether she was using any contraception in this cycle, or whether any unprotected sexual intercourse in this cycle, and are her cycles are regular, so that we can offer her an emergency contraception according to her history. Am I clear, Vilma?
All right. Okay.
Okay. After this, we should also check her medical history, her surgical history, her support at home, where does she live, and also if the patient's safety or and the safety of other women are at risk, then we should, after taking consent from this patient, we should involve other agencies to offer her support. Like we can involve SARC in this, we can involve housing safeguarding department in this, and also the rape crisis. These are certain support groups so that we can offer her a safety. Am I clear, Vilma?
Yeah, you're correct. Yeah, you're clear.
So now, first of all, after this, taking history, we will examine this patient and we will see whether is there any life-threatening injuries. Like sometimes patient do bleed heavily, and we need, if the bleeding is heavy and there are life-threatening injuries, then we needed to treat these injury as a medical person. Like maybe she requires stitching or all that. But if there are the minor injuries and they are not bleeding, then we should not wipe these injuries, because we needed to, the forensic person needed to take the DNA evidences from that. Am I clear, Vilma?
All right.
Okay, and in the emergency, we do have a kit that is called as an emergency kit, which contain a sample to take for a sample of a urine and a mouth rinse. So when such patient arrives in the emergency, we should take the sample of the urine and the mouth rinse in order to, so that the patient can become comfortable, that can, so that she can eat and drink well. Okay.
Yeah.
And after this, we should offer her the emergency contraception, that is in the form of a IUCD is the most effective form of a contraception. But if it is not available at that time, then we can also offer her emergency pills. Okay.
All right.
And we will also tell her that she should do her urine pregnancy test after 3 weeks, in order to keeping safety of the patient in the mind. Apart from this, we should involve the multidisciplinary team that include the gum clinic, the physician, infectious physician, and forensic team, who will do a proper examination. And this patient should be screened for other sexually shared infections like hepatitis B, C, and gonorrhea, chlamydia, HIV, and syphilis. Am I clear, Vilma?
Yeah, you're clear.
And this patient should be discussed regarding also the post exposure prophylaxis of a HIV, and that should be commenced within 72 hours of a assault. And it can take around 4 weeks. The treatment will take around 4 weeks. And also in the history, we should inquire about whether she is she has taken the hepatitis B vaccination. And we should start her, give her a fast track dose of hepatitis B vaccination, which is at 0, 1, and 3 weeks. Or we can also give a dose of 0, 1, and 2 months, and then give her a booster dose at around 12 months. Am I clear, Vilma?
Yeah, you're clear.
Okay, and after this patient, after providing her safety and referring her to the forensic team and to the SARC, we should document whatever the injuries we have noted. We should document the injuries in a clockwise position. After taking, like after by measuring tape, we should see what is the, we will take a anatomical landmark and we will take a measuring tape and we will see that what type of injuries are there, like it is a abrasion, laceration, or bruises. So we will write the injuries in a diagrammatic form, and the one who is examining the patient should write his name, sign, and date that. Okay.
All right.
And after that, we should give her a follow-up. The follow-up, first follow-up within a 3 to 5 days. The next follow-up within at the level of 4 weeks. In the first follow-up, we should ask her regarding what the complications. At the follow-up at 2 to 3 weeks regarding screening of infections, and follow-up at the 4 months regarding screening for HIV, syphilis, and this gonorrhea and chlamydia after the incubation period. Am I clear, Vilma?
Okay.
And it is very important to assess the mental health status of this patient. As I told you, these patients are at risk. Okay.
Okay.
So I'm going to give you some strategies videos so that you can go through that. So could you tell me how the session goes?
Yeah, the session was really enlightening. But Bismil, I'm just upset about the whole incident.
Yeah, I'm also going to provide you some support and help. And if you want off from the hospital, we will give you we will ask our consultant, so that you also need some support and help and off, so that you can also recover from that trauma. Okay.
Okay.
Thank you, Vilma.
Thank you, Bismil. Thank you. Well, good start indeed. Yes, you know the task, and you know what to speak for the task, except that you need to be a little more organized, so that maybe if you practice a couple of times, things will fall into place within the stipulated time. However, a few things, a few very important things shouldn't be missed, my dear. See, whenever the role players, whenever the candidate's name is given, the junior colleague's name, please address her. She's a colleague, right? So you can say, "Hi, Vilma. I'm this one. They say 5." So that could be a better statement, because if the name is given and if you're going to ask what's your name, that means you do not have situational awareness.
Okay.
Yeah. So it's not your role play task. It's not like you cannot ask like, may I check your name and age? No, all such things shouldn't come here. So she's just a colleague, all right? And yes, I'm not sure whether you were there in the beginning of this session. I was telling, whenever you see the task, if you feel that there's something that the role player is coming out with, settle that first before you travel. Otherwise, she may not be able to cooperate fully to the best of her extent if you don't ask her. For example, she told you in the beginning that she was a little, you asked about how the department and everything, you ruled out billing and undermining, that was fine. Then you asked her why she's interested in learning. Yeah, that's an excellent point. And then she told that she had a patient and all that stuff. Story she told, isn't that? Then she told she couldn't sleep the next 2 days. So you offered her to take a rota off from her, off from her rota. So that was a fine thing as well. That is not sufficient. That's why she asked you in the beginning. But I still feel distressed. So you have to ask her to go to the occupational health therapist. Yeah.
Okay.
So for patients, we send them to the counselor. We ask the counselor to come and meet. But for the colleagues, the doctors, the colleagues, the nurses, or the midwives, whoever it is, for us, it is the occupational health therapist. So that is going to settle her down. So as I told you in the beginning itself, whenever you sense that the patient is in pain, is in physical discomfort, she's vomiting, she is angry, or whatever it is. So settle her physical emotions as well as settle her physical needs, or settle her physical complaints as well as her emotional things. If you're going to do that at the beginning, believe me, my dear, she's going to you're going to have a very smooth sail in this task. Even if you forget something in the applied knowledge, even if you forget something in the something in your percentages or something, they don't mind it. So believe me, there was a candidate of me, again, one of the Egyptian girls, who took one-to-one session with me, and believe me, she cleared in January, the part 2 in January, and she came to me fresh in March, right? She didn't take any other course, any other mentorship. And that time it was like Ramadan also, but she could be able to make through a success. She scored very high scores also, the first ever attempt, she said that the patient had some PMS. That was a case of PMS. This girl told, "Don't worry, even I have also PMS." And the role player laughed, and she also laughed. So what I'm trying to say is, you try to befriend your role player. She's going to help you to succeed the task. Okay, instead of conducting like an interview, instead of let your tension level or your nervousness shouldn't override your conversation, shouldn't override your communication with the patient. That is very, very important, my dear. All right. So here, Vilma Thomas is your colleague. So start with an open statement. "Hi, Vilma." So that could be a better statement instead of asking what's your name and age. Okay. Right. Yeah. And yes, you were correctly telling about and then you asked about her. She told about the expand about the incident, and you were systematically going. But I would suggest that you can just see about tip-to-toe examination, right? So that could be a more apt statement instead of saying this examination. Of course, you told that we will be measuring the length of the this thing, and you should not wash, wipe things, and you should wash. So all that is fantastic. However, it would be better that if you can just explain to her that what is meant by sexual assault, and it is carried out without the victim's consent, and then ask in detail about what sort of this thing. So thankfully, you didn't explore much details about that particular incident. Maybe if you're told that, could you tell me the details of what actually happened to her, then that means your confidentiality, you're making Wilma Thomas to lose her confidentiality that the patient interested on her. So thankfully you didn't do that, I can see, because this is one of the mock questions. This came from my mock exam. This I kept from my mock exam. So the very same question the students got in the examination, but so many of them made this mistake. So when I did the mock feedback with them, I corrected them. So thankfully they all clear with very high scores and they got the same task. So what I'm trying to say is, you have to be, as I told you, it is for any other task, for any other task. For example, any other teaching task. For example, she's going to talk on some CTG or she's going to talk on some eclampsia. You have to always refer to the index case that is given here. But in sexual assault girls, please, 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 heaven's sake, don't ask about the details of that particular incident that happened to that particular one. Okay, just ask about what made her to learn about the sexual assault. Okay, so and as well, you can, when at the time of fixing agenda, you can also ask her that, just, you can reassure her, and you can say her that at the end of the discussion, I'll be offering some educational resources to you, like the strategy links, the talk article is there. So all that you can always speak, not necessary to wait at the end, because in the beginning also, because sometimes if you're going to, because you told me almost at the end of the 10th minute, so which may not be a favorable thing for you, you might tend to lose marks. Okay, so in such cases, please, when you do the agenda fixing, you can say that I'll be able to give you some links, some strategy links, as well as there's a beautiful talk on sexual assault, and I'll be able to give you that, and you can read that. And in case of doubt, or if you're finding it difficult, you can always feel free to communicate with me anytime. And believe me, one of my girls in the November exam, no, in the February exam, there was a case of eclampsia, and there's a male, a boy role player, and she was so friendly that she talked to him. Okay, next case, if I get a eclampsia, I'll call you, and I'll give you my contact number. So for any other concerns, you can always talk to me. And then the role player laughed at her, and he winked at her, saying that, oh, that's really nice of you. So that should be your communication skills when you communicate with your role play. And this particular girl, she scored very well. She scored 80 plus. Right. So a trip to examination would be an ideal thing. And yeah. So please, whenever there's something so sensitive issues, of course, you'll be signposting, you'll be confiding confident, you will be ensuring confidentiality, and you'll be saying that I'll not be exactly ask precisely how many hours have passed since the episode, because that will determine what sort of an emergency contraception you're going to give to this woman, as well as ask whether she has been just beg a pardon, so that she shouldn't feel offended, because she's being reminded of her the incident, the traumatic incident, and that might produce her more, that might upset her more. So always, it is the duty of the doctor to apologize to the patient, saying that I'm sorry, I'm not here to make you remember all these bad memories, but that will help us in our communication, in our management plan. So that will be when you deal with the sexual assault case. But here, still, you have to educate this girl, Wilma Thomas, to take such a history from the patient. All right, and then of course the confidentiality, and whether this particular incident has been informed to the partner or to her family members. And yeah, when was the last intercourse with a partner? Okay, that was whether it is a safe sex or not. Okay, then of course the tip to toe examination. So minor injuries, suturing not required, and should not be cleaned, because samples have to be taken, and then shape, the depth, and the tenderness, the color, using a body diagram and a tape measure is very important. And that will be measuring the size of the injury, as well as the distance from fixed anatomical landmarks. We can photograph the injuries with the patient's permission. That is again by a trained specialist photographer, and with the written consent of the patient. Remember, it's a written consent. She should also not drink or eat or pass urine previous to the evidence collection. And all these has to be in a sealed cardboard box containing a plastic pot for the urine sample, a toilet paper tissue, and then mouth swabs and mouth rings, and instructions on how to use the kit. The collection of the samples can capture vital evidence and should be taken at the earliest opportunity. Early urine sample. An early urine sample may increase the chances of detecting drugs with alcohol that might have to use to facilitate the sexual assault. This is again an important patient safety aspect. A mouth rinse sample may detect any vital evidence whether any oral penetration has been alleged. The contents of the kits may vary, but the minimum requirement is urine collection and a mouth rinse. And the forensic department, toxicology, and police may have to be involved, of course, with the patient's consent. Investigation, pregnancy test, HIV, syphilis, hepatitis B and C, or vaginal, anal, and oral swabs, and screening for the STIs. Okay, women should be referred to the local sexual health clinic, and most screening for STIs should be done 2 to 3 weeks after the assault because of the incubation period of these pathogens. Neisseria, gonorrhea, chlamydia, and the NAT test should be taken from the site of the assault, including the pharynx, the vagina, the anus, and treatment is pregnancy preventing precautions that is using emergency contraception according to the LMP and according to how many hours is precisely passed after the attack. And then, of course, the copper iode is the most effective form. So we have to talk a bit about the emergency contraception. HIV post-exposure prophylaxis should be discussed with every woman, should be started as soon as possible, but within 72 hours and continue for 4 weeks. Vaccine against hepatitis should be given. Accelerated course of hepatitis B vaccine, yes, you're correct, entailing 0-1-3 weeks or 0-1-2 months and a booster at 12 months. You are excellent in telling. And whatever all these patients concerned, an antibiotic against chlamydia and 2 weeks back. Repeated again, prophylaxis against the bacterial STI is rarely offered, but can be considered on those whose risk of infection is high and who are unlikely to attend for the follow-up clinics. And prophylaxis has got a limited role as it might lead to unnecessary treatment, reinforce belief that there was a high risk of infection and that might miss out on the partner notification. Blood test at 3 months should be offered to screen for hepatitis B and syphilis and HIV. Symptoms of post-traumatic stress disorder like flashbacks of or nightmares, irritability. Yeah, we are correct in telling about all these psychological problems. Sleep problems can occur. Emotional numbing, meaning lack of ability to experience the feeling. Very important, last but not the least, if at all she got any suicidal ideas, she tends to, have some feels that she has to commit some self-violence against her. She's very aggressive, so that is the time that she needs help and help and support to help her to heal out of this post-traumatic stress disorder and such events. That is very, very important to say that if she develops any feelings, she has to be, she has to report us immediately, given the 24/7 contact numbers. If she wishes, she can involve her parents or her partners, and those, those members also will be educated about this. Of course, we have to talk a bit about SARC and Mrcog, very important. We told about the SARC as well as the multi-agency risk assessment conference team also has to be involved. So they will provide practical emotional support and information, and they can get the link with essential services such as victim and witness organizations, counseling, and healthcare providers. We're ensuring that the safety of the victim is coordinated with all these agencies. All right, and then of course, you just ask Ilma about how the session went by, and then if you have time, you can just say again, you can reassure her by giving a educational resources. So the take-home point is please settle the role players' emotions, travel with their agenda, and have an impressive start in the beginning. Any doubts on this well, my dear?
Dr. Guna, the follow-up first follow-up is at 3 to 4 day, or first follow-up it is at 1 month?
Yeah, generally after, you mean the follow-up for which one? For the post-exposure prophylaxis, or is it for the sexual, it's for the sexual infection, STIs?
No, it's for the sexual infection STIs at the 3 weeks, right?
Yeah, 3 weeks.
But for the post-exposure prophylaxis, if she has taken the post-exposure prophylaxis, then at the 4 month. But the first follow-up, the patient with the sexual assault should be given within a 3 to 4 days or within 1 month. I'm puzzled in this.
Yeah. So the thing is, like, you have to clearly specifically say that for the Pepsi, for the post-exposure prophylaxis, HIV is to be started as soon as possible, but at least within 72 hours. In the event of she doesn't want to take, she's upset, she wants to relax sometime, she has to take it anytime within 3 weeks, within 3 days. But for the STIs, you're giving her a course of antibiotics. And suppose if she's got some, some bite marks, some abrasions, some lacerations, you're going to give her a tetanus toxoid as well. Okay? So you're doing the initial cover-up. So you can ask her to come after 3 weeks for the pregnancy testing as well as for the sexual health clinic follow-up.
Okay.
Yeah, you can just brush up the talk, my dear. So everything is given very clearly in the talk, and a few things in the strategy also. So any other doubts in this, my dear? My dear Bismil, any other doubts?
No, Dr. Guna, thank you.
Thank you. So any other doubts, friends? Anyone else? Do you have any other doubts? Any queries for me? Right. So in the event of no other queries, so let us wind up the session by, you can contact me at smartment.ment@gmail.com or the Telegram group or the Facebook group. The other mentors are there, the moderator is there. Anyhow, they'll be reaching back to me with any queries which has been posted on the Facebook group or the Telegram group, or you can directly send a mail to me, smartment.ment@gmail.com. So I'll be replying within 24 hours. So any other doubts or any other queries? Otherwise, we'll wind up the session. Thank you for staying with me for almost, I would say, 4 hours. We are, 3 hours and 45 minutes we have been together. So thank you for the participation. Anything that I need to answer or I need to address, please come up. Right. So I think everybody is almost tired at the end of the day. So for Indian guys, and yes, Annam. Is it Annam?
Yeah, doctor. Yeah, but I think too late.
No worries, no worries. You're coming and going. I do not know. It's okay. That's fine. So thank you guys for joining. Wish you a pleasant evening and good night. And Eid Mubarak, advance Eid Mubarak to all of you. Thank you so much and bye-bye. So the recordings will be posted in the YouTube as well as in the group. Thank you and good night.